On behalf of Drs. Saab and Brown, I hope that we have a very informative session. We have decided to keep in the same format that we've used the last couple of years. We're going to do a complex case journey of a young woman that has a long history with autoimmune hepatitis, cirrhosis, pregnancy, postpartum issues, and beyond. It's going to be interesting, complex, and hopefully with lots of controversy. We're going to discuss this in 5 sessions and 5 different panels. And the moderators, as I said earlier, are Drs. Brown, Dr. Saab, and myself. And we'll try to speak as little as possible and let our panelists teach us all. So let me introduce the first panel. We're going to introduce the case. So I'd like to ask Dr. Nitika Gupta to come join me on the stage. Dr. Gupta is a professor of pediatrics and a pediatric hepatologist at Emory University School of Medicine and Children's Healthcare of Atlanta. She specializes in treatment of children with liver diseases and liver transplant. And next, I'd like to invite my boss, Christina Hansen. Christina Hansen is a board-certified nurse practitioner at South Denver Gastroenterology. She specializes in the care of digestive and liver diseases. She specializes in digestive and liver disease care with a patient-focused approach.
And I specialize in trying to take care of you.
That's exactly the case. And last but not least, Dr. Brian Lee. Dr. Brian Lee is a transplant hepatologist and associate professor at the Keck School of Medicine at USC. He specializes in alcohol-associated and metabolic liver disease and leads research to improve patient care and outcomes. So, panel, thank you for being here. And let's talk about this young lady. These are our disclosures. So this young lady, her name is Maya. She's 17 years of age. She is referred to us from her primary care physician's office for elevated ALT and AST. She has a past medical history of eczema, a family history of diabetes, hypothyroidism, lupus, and coronary artery disease. Her social history, she has no reported use of alcohol, smoking, or vaping. Her BMI is 22, and these are the labs. Let's say it's a mixture of the labs gotten by the PCP and some that we do ourselves. So her ALT and AST are moderately elevated, 244 and 230 units per liter respectively. Total billy at the upper limit of normal at 1, alpha somewhat elevated, 158. Normal albumin, normal white blood cell count, hemoglobin, hematocrit, and platelet count. Her hemoglobin A1C is normal, iron saturation is good, ferritin is good, and her lipid panel is okay. And we get some serologies that are negative, the anti-LKM1, because in young people, not everybody has type 1 autoimmune hepatitis. Negative viral serologies, acute and chronic. And she has a negative celiac panel, negative ceruloplasmin. Yes, we do check ceruloplasmin in young people with significant hepatitis. And she has an alpha-1 antitrypsin phenotype that is MM. But she does test positive for an ANA, a titer of 1 to 1280, a smooth muscle antibody at a titer of 1 in 80, and an IgG that is elevated at 2240. We get a liver ultrasound, which is interpreted as showing normal liver parenchyma, increased hepatic echogenicity, a liver contour that appears nodular. And I don't know if all our radiologists need glasses, but every ultrasound that I send out there looks nodular to them anymore. 100%, right? And she has a normal liver and spleen size. And so the radiologist interprets this as possible cirrhosis, no evidence of portal hypertension. We do a fiber scan, which is part of our physical exam in hepatology offices, and her CAP score is 200. This correlates with a stage 0 for fatty infiltration, and her liver stiffness measurement is 10.85 kPa. It actually is 10.8. The typo didn't get removed, and that would correlate to about a stage 3 of fibrosis. So that's it for me. It's your turn, guys. So, Dr. Gupta, tell us, she comes to you first. How do you approach the diagnosis of autoimmune hepatitis in your practice?
Yeah, so thank you, Marcelo, and thank you for organizing this this session, because I think it's really important to have the continuum of the disease. So she's already coming to me with a high total IgG, ANA, SMA positivity. So my next step is going to be definitely a liver biopsy, because we have to make a liver biopsy. We have to do a liver biopsy to make a confirmed diagnosis before we put them on. What we see in pediatric age group is almost lifelong therapy, with very few patients being able to come off.
Excellent. Dr. Lee, anything that you would like to add to that?
No, I agree with Dr. Gupta. Certainly liver biopsy is required for the diagnosis of autoimmune hepatitis, which would be the prime suspicion at this time.
Christina?
We have to give you something to do. So no, liver biopsy. Yeah, that would be our standard. Yep.
Yeah, we feel that most of these patients are going to be on lifelong treatment.
Right.
So and not all the medications are a walk in the park. So if we decide that they're going to be on lifelong therapy, we better get it right? So that answers our first question. So we agree all that we need a liver biopsy. Regardless what some guidelines out there might say, we want to have a liver biopsy in order to start therapy. So we did a fiber scan on her. We didn't calculate a FIB4 or anything else. Dr. Lee, tell me about which NILDAs do you like to use. She definitely has features of advanced liver disease, not just the radiologist, but our fiber scan, maybe a lowish platelet count. She does have compensated adult advanced chronic liver disease. So which NITs do you like to use?
Well, obviously NITs have been most validated in MASLD, and there's less data in autoimmune hepatitis, but amongst those that have been studied would include FibroScan, MRE, and the most would be FibroScan. So that's the one of choice. One caveat here is that any inflammation can overestimate the liver stiffness. So this patient has an ALT of 200, but anytime the ALT is above 100, I always look at the LSM result from FibroScan with a little bit of skepticism. So I would certainly repeat the FibroScan, after she has biologic response to assess for a baseline stiffness.
So you find that active inflammation may skew your stiffness measurements in VCT.
Correct.
Dr. Gupta, we learned yesterday that unfortunately NITs or NILDAs are not very well established in pediatric liver disease. How would you go, let's say that you don't have the liver biopsy yet, how would you go around assessing the advanced component of her condition at this time?
Yeah, so we really don't have any of the NITs which have been validated or useful. So we'll do a FibroScan in clinic. And again, like you're saying, we don't focus on one value, but it's more, repeating it and having serial FibroScans, which help us as part of the puzzle. But without a liver biopsy, it's hard to proceed in this one. And once we have a biopsy, we can continue doing FibroScans and follow the biochemical response. And again, just to know my spectrum of autoimmune hepatitis, the youngest I've had is a 9-month-old baby who presented with acute liver failure. So again, they're even less validated. You could make a case she's approaching adulthood maybe, but we see 2-year-olds, 6-year-olds, 12, the entire spectrum with autoimmune. So we really don't have a whole lot. And FibroScans also, we start from like 8 to 10 years of age when the child can handle, even the little beeps they may not be able to handle. So
yeah. We all agree that the value of FibroScan is its negative predictive value.
Yes.
But the positive predictive value may not be as reliable. And oftentimes when in question, then we'll go to either another NIT or liver biopsy. So, Christina, else, MREs?
Well, I was going to agree with Dr. Lee as far as any confounding factors with this patient. That would maybe be an overestimation. It would be that with the inflammation, she's thin, she's not obese. Imaging didn't show any other kind of liver lesions, so can feel fairly confident. But again, relegating, as you said, with liver biopsy, we want to know that this is a diagnosis for a long-term therapy. But relegating someone to a diagnosis of advanced liver disease or even cirrhosis, for that matter, we want to make sure. So if there's any question about it, probably my personal choice would be to try to get MRE. Would be my next. Alpha certainly is an option, and it's obviously gaining traction. We're using it more, but historically in our practice, more for research. But cost is obviously an issue with MR and accessibility. So, but that would probably be my next choice as far as a NILDA. And repeating it, continuing to follow it, put her on treatment, and then get a reassessment of what that looks like once that inflammation is down, and continuing to follow.
Okay, so our pathologist agreed with us. She does have autoimmune hepatitis. So I'll start again with you, Christina. How are we going to treat her? And I'll pose the first question to you. Let's talk about different kinds of steroids or no steroids.
So we tend, if we have a fairly mild case, unless we have fulminant or really severe, to try to avoid steroid use. We're not in the hospital as much anymore, so we don't see those more severe cases fulminant. But when we do tend to have a case where we use steroid, we do tend to use budesonide over prednisone. But if we have a very mild case, this is something where we may consider not using steroid.
Yeah. Dr. Gupta, how do you approach your pediatric patients are more rambunctious than adults?
Not all adults. No, that's a great question. And ASLD came out with their recommendations a few years ago, and where they said that budesonide should be considered as first-line therapy. And if you look at it, was based on one study. I think I would like to make a case here for what you actually said very subtly, if it's a mild patient or if it's a mild disease. So I think when we read these guidelines or assessments, we really have to keep in mind who is our patient population. So I'll start with my patient population. Their immune system is aggressive. 40% of my patients are African Americans, again, an aggressive immune system. And in our experience, what we've seen is nothing else works other than prednisone. So I will put them all on prednisone. We kind of max it out at 40. We do 2 per kilo, but max it out at 40 a day. And then the goal is to try and get them down quickly. So kind of hit it hard in the beginning, see a good response, get it down, start Imuran, and then continue on very, very low dose prednisone. Have I started budesonide? I have. It was a patient, again, very mild, just one case in my 18 years of practice. ALT, AST was in the 40, 45s, but SMA was positive. Biopsy showed very little inflammation. So I was like, let me try her on budesonide. So again, a case-by-case selection, but majority of pediatric patients I know go on prednisone. So we've never done a no steroid start. I've used Cellcept, Prograf as second-line therapy, but along with low-dose prednisone.
Perfect. Brian, let's say that our ALT and AST are 2,000. Do you do anything different?
Yeah, I think about, treatment for AIH and induction, and then, maintenance of the remission. So for induction, whether she had, ALT 200 or ALT 2000 right now, I would be using prednisone. There's concern for advanced fibrosis in this case, which would make me concerned for budesonide. As Dr. Gupta mentioned, she's young, and it may be more challenging to induce remission. So I would really be using prednisone as first line here.
Yes. Let me modify it again. let's say that she is 65 years old. Her highest transaminases have been 42. She has stage 2 disease, and you choose to start mycophenolate as your first choice. Does she need steroids?
Or challenging, so I would say that AIH in general, it's high unmet need for randomized clinical trials. So, there was recently a randomized clinical trial using CellCept versus azathioprine in combination with steroids, and it seems that there's higher rates of maintaining remission and lower adverse events. So if you're going to extrapolate that data, you might think that, the patient that you've mentioned who's older, who might have more adverse events from steroids, that would be, an ideal candidate for MMF. That being said, it really hasn't been studied in that era. So I still use steroids, but I'm certainly trying to taper that person as quickly as possible. And I do use CellCept in those patients. So, rather than azathioprine, I may consider CellCept instead in those older patients.
Because I think in this case, if we're talking about our practice, or if we're saying how would we treat this patient, that would be different too. And you were saying, this is advanced disease, and we're not sure, stage 3 potentially more. That's something that we wouldn't want to be using budesonide. And she's 17 at this point, but she's technically childbearing. So MMF, these are not choices that we'd be considering in this particular case.
Christina, I'm going to ask you to defend our practice. I think the rest of the panel likes steroids and probably will keep the patients on steroids longer than we might. Why might we not?
Keep them longer? Well, I think the risk of steroids long term. I think that's if we're seeing response and obviously achieving remission, I think we like to try to taper sooner than later. Budesonide, if we feel maybe it has a little less systemic potential than prednisone, but even then, although we like to declare stability for quite a while before we would completely taper off. So I think once we get to that normalization, we still will wait 6 to 12 months before completely tapering off. But I think just the long-term side effect, you've got a 17-year-old, but I'm not in the pediatric world either. So, getting that inflammation down is the to point in her case, especially.
Let's say that this patient has been stable for 2-3 years on treatment with transaminases and IgG now in the normal range. Would you two consider tapering off the steroids, or is this maintenance forever?
That's a great question, and something we grapple with in clinic all the time. So first of all, in my population, there are very few who remain, and we've published on this before, very few who have normal liver enzymes on minimal steroids, but there are. So I will always, again, this is ASLD also recommends this, 2 years of normal labs, minimal steroids, 2.5 or 5 milligram daily, do a liver biopsy, and then see. And I've done liver biopsies, and I have patients who were completely normal. So I did take off prednisone, but continued on azathioprine. I've had a patient who was diagnosed at 2 years of age. We did a biopsy at around 6 or 7, she had mild inflammation. And we discussed shared decision-making. The parent said, Dr. Gupta, you have around 2.5 milligrams Monday, Wednesday, Friday. Why do we want to rock the boat? Just keep it at that. We kept it, and she's now 18, starting college and doing great. Data also shows, and again, you have to read these data very carefully. It says about 20 to 40% of pediatric patients can stay off of steroids. But if you reverse that, that means 60 to 80% will relapse. And when the relapse happens, it could be really bad because they may be lost to follow-up. By the time they come to you, they're already fibrotic or cirrhotic, being off of therapy. So I would really caution people about when we take off prednisone, it has to be a candidate who will maintain good follow-up. But I do have some, I've taken off prednisone, but continued Imuran.
I'm going to emphasize what you said is if you have somebody that has more advanced disease or had a more aggressive presentation, any sort of remnant inflammatory activity in the liver will denote a higher risk for recurrence, and lack thereof, a higher likelihood of being able to take off medications or do minimal medications.
And when they present, they will present with portal hypertension and fibrosis, not an inflammatory phenotype. So that also gets missed. Somebody who's been off of therapy, we've had a few, came back 5-6 years later, and the spleen is huge, platelets are 30, and I'm like, there's no point in starting prednisone now.
Dr. Lee, we're going to talk about this all day long, but is it azathioprine or MMF?
Classically, azathioprine has been, the standard of care for maintenance. The value of azathioprine is that you can monitor it with, metabolites. It's been well studied. You can titrate it. But, MMF, it may have higher efficacy and lower adverse events. So I've been using MMF more. For this patient, I probably wouldn't, given the risk of, pregnancy and the complications from that. But in an older patient, it's something I would certainly consider.
Christina, do we do different?
Yeah, I think azathioprine standard of care, but we get concerned about the risks, even long-term, with squamous cell. And unfortunately, we've seen them develop. In her case, no, I would tend to do the azathioprine for the teratogenic effects of MMF later in life, or potentially, surprises. But I like the idea, the faster acting, the efficacy. We have seen in studies that it's showing good efficacy, and then safety. So we're seeing a little bit more use, I think. I like the idea of it for the sake of debate, but if I really think about it, we don't have a lot of patients on it. But for that case where it is someone that's maybe an older individual, a male, that the occasional male that we have, that I think it's an option.
Yes, please.
Yeah.
I think one thing we haven't talked about, once daily versus twice daily, at least in my population, it makes a big difference. It may seem like a small thing. I've seen kids get more diarrhea on CellCept, so we don't like using that. And then childbearing age. And then compliance is a big issue with teenagers. So that's another reason why I would lean towards azathioprine.
And choose your side effect profile and
Yes.
risk profile.
And we have, again, long-term, that's where we need a lot more studies and randomized controlled trials, because I don't know the 17-year-old or the 12-year-old who I sent to the adult side at 25, 30, how she's doing. I don't know that. So we really need this long-term data. I hardly see any side effects from azathioprine. Very okay. One patient maybe who developed leukopenia, which again, some portal hypertension too. They do great with prednisone. Again, a small percent who have growth issues. Now, bone density is something which I do see drop. So we start checking and kind of staying on top of that. But I don't know what happens to them at 30. And I think that's a big gap.
Yep. Dr. Lee, azathioprine, which I like the fact that you like to check metabolites. I know that not everybody does, but it does take a while to kick in, right? But MMF kicks in earlier. Tell me about dosing. Do you go for 1.5 mg per kg in everybody with azathioprine? Do you go for 1 gram BID or 1.5 grams BID of the MMF? And since they have a different onset of action, does one need steroids and the other one not? Or how do you manage that?
So I started sequentially. So for example, azathioprine in practice, you're seeing these patients in the hospital, you're starting induction therapy with prednisone, and then I send the TPMT. Then I schedule a follow-up in 2 weeks, and then I start azathioprine for a goal of 1 to 2 milligrams per kg. And really I'm monitoring them very frequently to assess their response. For CellCept, I'm starting 500 BID. And for up to 750 BID. It's been my general practice.
What do you do?
Yeah, for for azathioprine, pretty much similar. I like to do it sequentially as well. And actually, the reason I also do that is I like to see the response to just prednisone. It gives me an idea of how this child is going to do if I see a very quick response with monotherapy. I've had like a handful of patients where the parents did not want to start second line. And I was like, well, that's the recommended thing. And because they show great response to prednisone within 1 week, from thousands, it came down to like 400 and they've stayed on monotherapy, but that's been a parental choice. But otherwise, it gives me an idea how they're going to respond. I start azathioprine and then monitor. And like I said, I don't do CellCept, so I don't have much experience with that.
We did touch on peripherally on the choice of medication given that she is in reproductive age. Let's say, how do you approach that conversation with the girl and with her family?
About CellCept?
About CellCept, and if they choose, she could have problems where she get pregnant.
Yeah. It's something we just normalize, and it sometimes becomes uncomfortable. So we've had situations where a parent is like, why are you talking about pregnancy? She's 17 or something. And so over the years, we've just learned, because especially with our transplant clinic, CellCept use is very, very common. So we have pharmacy, we have educational sheets. So we talk about CellCept and pregnancy all the time. And even in a 17-year-old, sometimes the parents and the child or the teenager is asking questions about, long-term reproductive health when you make a lifelong diagnosis.
At what point in time do you send her over to us, and how do you make that happen?
So, great question. So I know in the pediatric world, every hospital system is different. Our hospital system did a good thing, was that they determined that 21 was the cutoff age. And we can spend the next 2 hours discussing pros and cons of having a cutoff age. But it did help us because we start preparing our patients for transition, knowing that at 21 they're going to go. Are they ready? Are all of them ready? No. Are your kids ready to go to college? No, not all of them are ready, right? But we still do send them. So we start the process of moving them over after 20. And it's sometimes in the middle of college, sometimes towards the end. But I think that's been a good time. I wish I could do that after college finishes, but it's worked out for us so far. And we have a transition program for our transplant patients, but not for our liver patients, just because of resources and time. But we send them to our partner Emory adult group.
We have different conversation or messaging when we talk to the actual pediatric patient or to the parents. Do they have different challenges that they are concerned about?
Yes. So we try to, once they're over 14, 15, I try to really, for a teenager, make sure that they are involved in the discussion. I think it's something which we as pediatricians could do better, because we like talking to the parents. They are adult to adult conversation, right? But we really need to involve the teenager and the patient. So the conversations are certainly different. The questions are different. But I always try to emphasize self-care, self-management with support from the parent. I never kick the parents out of the consult room, because we've also seen that the parents who just give up once the child turns 18, and there are parents like that, believe it or not. So you see helicopter parents, but there's on the other side of the spectrum as well. Both those kids don't do well. The helicopter parent kids and the parents who just become totally hands-off. So we need parents as guardrails, especially till about 23, 25. That's when the brain fully develops for executive functioning. So when you guys get a 21, 22-year-old patient, please realize that they're not fully there with their executive functioning, cognitive things, especially the ones with long-term chronic diseases. So it's good to have the parents, but the conversation should also always be with the patient. That's how we empower them.
I've started to have that with that transition ask the patient to bring their parents in, because for you like talking to the parents, and this a 21-year-old, that's not, I mean, it is an adult, but it's not an adult. And that transition, I agree with you. It'd be nice if you could wait till after college, because they can get easily lost to follow up. They're not as compliant. And I'm thinking about one particular patient in mind that I couldn't get to follow up after establishing care. I said, you need to come in, you need to do your assessments, and please bring your parents there too, just to help, like you said, with guardrails and to have those hard conversations.
And also to realize, remember our time when we were in high school, college, you're having fun, you're having parties, and then suddenly, bam, you are told you have a lifelong diagnosis, and let's start prednisone, 40 milligrams, and you get Cushingoid. For young females, it's a big deal. We had a kid who was diagnosed actually around this age, super compliant, high GPA, going planning for IVs, and after starting treatment, did well for 4 months, and then decided, I'm just not going to take anything. Because it's a lot. So even for the kids who are well-spoken, kids, teenagers, young adults, who are well-spoken and doing well in school, doesn't mean that they're going to be able to handle this new diagnosis, which is lifelong well. So I think it's also important to provide support and potentially therapy. I talk about therapy early on because I think it does help coping with a new diagnosis.
Well, thank you to all three of you. We have run out of time, so I very much appreciate your comments and contributions. Thank you so much for being part of this.
So I have the pleasure to moderate the second part of this, of the 5 session. And now we're seeing this young lady develop progressive liver disease. So I have the privilege of inviting the next panel up here, Dr. Pierre Guillaume, who's actually was kind enough to change his flight to stay with us. He's a professor of medicine at Case Western School of Medicine, the medical director of the Liver Center of Excellence. Our second panelist, my dear friend and colleague, Dr. Singh, who's a transplant at UCLA. She's actually co-started a post-transplant alcohol clinic and leads a pre-transplant alcohol clinic with our addiction medicine specialist. And then also another dear friend, Dr. Avash Thulabas, who's a transplantologist, physician scientist at Columbia University, who specializes in cirrhosis and making a name for herself in the field of frailty. So let's move on. So here's our disclosures. Pierre, you have the most. You're a busy man. As mentioned, these people with autoimmune liver disease have a life, and she goes off to college, and like many people in college, they think they're invincible. And so she comes back to your office after a number of years, and you're able to access the student health records. And there's notes that she's been less in adherence to medication, skipped a lot of days of her autoimmune medications. And like most college kids, she's been drinking alcohol, in particular binge drinking. She comes back, she's now 22 years old and engaged to be married. So you do, the routine blood test, check the liver enzymes, and they're still mildly elevated. You notice her platelet counts a little lower, 147. You make note their album is below 4.0. IgG is 1832. And her PET test is 480. And we're going to talk about the role of PET tests in clinical practice. You're going to hear different opinions from our panelists. And as our extension of our examination undergoes a transient elastography, and her score is 21. So first of all, for Dr. Thulabas, so we have many people on, with autoimmune hepatitis. How in your practice do you follow patients? How often do you see them? How do you monitor a blood test? How do you counsel them with autoimmune hepatitis? Now that she's 22 years old.
Perfect. Yeah. First of all, thank you so much for inviting us to be part of this panel. I think this is a great format. I think obviously every patient is very different, and we have to modify how we monitor these patients based off of a lot of factors. The first thing is this patient actually in remission or not? And that's the biggest factor that I would consider. Obviously, in this case, it does not seem like this patient's in remission. Patients in remission, I follow them less frequently in terms of labs. I space labs out to every 3 months or so and see them in clinic less frequently. But in patients that have a new diagnosis of autoimmune hepatitis that we're initiating steroids on, we're tapering steroids and starting azathioprine, for example, those patients I'm getting labs every week as we taper their prednisone down and then start the azathioprine. And then once I see the liver enzymes improve, their IgG levels normalize, that's when I start to space it out much further. The other thing that I would think about is switching medication. So are we changing the pharmacotherapy? And is there a chance that this patient is going to be less adherent in that setting or have a flare up? And I would monitor liver tests much more closely in that setting. And the other thing, we talked about reproductive health a little bit. So in the postpartum setting, for example, when there's a higher risk of flares, I might monitor liver tests closely there. And then in terms of the labs that I look at, just the typical things. So CMP to look at liver tests, CBC to look at signs of cytopenias from these medications and signs of infection, PTINR, and then IgG levels. And we can talk about these metabolites as well. I don't want to take up too much time, but one of the issues that we always think about is, are these patients actually taking their medications and we're not getting sufficient response, or are we underdosing these medications, or is there something else that we need to do? So this is taken directly from the EASL guidelines from 2025, and it actually was I thought it was really helpful to look at how we can use thiopurine metabolites. So here you can see that you can use the 6-TGN and the 6-MMP levels to guide how we manage it. So we want for 6-TGN our range to be somewhere between 230 to 450, and so if we see that both the 6-TGN levels and 6-MP levels are low, we can say, hey, do we need to increase this dosage, or do we need to talk to these patients about adherence?
Let me ask your colleagues, Pierre, are you, or Jason, are you guys taking metabolites in individuals, azathioprine?
So I am actually not routinely checking metabolites. It's very well established in IBD and their literature. It's not something that I have yet adopted into practice, but, moving forward, especially, with these recent guidelines, may be part of my practice.
So how do you follow patients? Their cell count, CMP?
Yes, correct. Yeah. So I think azathioprine becomes a tricky medication, autoimmune hepatitis, because, it can cause hepatotoxicity, can cause NRH. So sometimes, one might think that the autoimmune hepatitis is not well controlled, but it actually may be a drug-related issue. So I do think it becomes challenging. I think the role of biopsy in autoimmune hepatitis is, much more necessary than in other disease states. And so that may also drive some of my practice.
Pierre, how about, do you check metabolites for your patients?
Yeah, I will freely admit that up until recently, I did not routinely check TPMT and 6-TG levels until our fellows started shaming me into it.
Good for them.
I did that based on the one paper by the great Al Jaya that suggested that it rarely, if ever, changes management. And to be completely honest with you, that has been my practice so far. I can't think of the last time I had to make changes to the management of the patient based on this test.
Are any of you looking at MRI PDFF for inflammation in people with autoimmune liver disease to gauge efficacy of medications or when you stop it?
I think in terms of azathioprine, I do check these metabolites, sometimes not regularly. I don't do MREs necessarily as frequently to assess disease. I do agree with Dr. Singh. I feel like I'm much more likely to rebiopsy a patient to assess the level of autoimmune hepatitis activity rather than relying on non-invasive markers.
Do you guys rebiopsy patients with autoimmune? Jesseline or Pierre?
Yes, yeah, I biopsy,
Rebiopsy?
rebiopsy, yes. If I feel that, either it's a drug-related effect or if it's, uncontrolled autoimmune hepatitis, I think that biopsy for me is the gold standard.
How about you, Pierre?
I mean, I've become increasingly averse to rebiopsying unless there's a clinical question that needs to be answered. In this particular case, there's probably a significant contribution of alcohol to the patient's presentation, so I may not feel that that is necessarily an absolutely necessary thing. So the generic answer is, for the most part, I tend to not rebiopsy the patients.
I think, there is a lot of concomitant MASH as well. And with steroid use, I think that that is a consideration. I think that's another reason that I end up doing, many biopsies as well, is to see how much of this may be MASH, versus autoimmune hepatitis.
In the audience, do everybody rebiopsy after a year of therapy for autoimmune hepatitis? Do people rebiopsy? I do. I tend not to, because according to I could be wrong, but according to guidelines, if you do a biopsy and it shows inflammation, and they have normal liver tests, you go for another year. Why not just go for another year and avoid it? But I'm hoping for better non-invasive tools. PET tests. Let me ask you guys. You guys all use PET tests in select patients or are your patients? And who are those patients? Oh, sorry, start with that. Go away.
So I check PETs pretty frequently. I think that the utility of PETs, even in a patient that is saying that they're drinking heavily, is helpful in terms of longitudinal monitoring and seeing down the road if they say that they're not drinking as much, are these PET levels actually coming down? And sometimes we see obviously that discrepancy that could push us potentially to suggest starting medications that we have at our disposal. So yeah, I test PETs pretty frequently on all of our patients.
Most patients or select patients?
I sometimes check. I check it on their initial evaluation on most patients. Yes.
Okay.
Yeah.
Jesseline, how about you? What's your practice like?
I am actually more selective about checking a PET test. I want to know if it's going to answer a clinical question. So if I think that someone is underreporting to me, or if I think that alcohol is contributing to their liver disease, then I will check that. But I'm not doing it on all patients.
Pierre, what's your style?
So my longstanding collaborator and clinical coordinator says that her life was a lie until PEth came along. And I very much agree with that sentiment. I check PEth on every single patient. Every single patient who's new who comes to see me gets a PEth test done as during their initial workup.
Wow.
Yep.
But it's great because you're having three different styles. From three different experts. I appreciate that. Maybe Jesse could walk us through the PET test. What is it? And are these numbers high, low? Are they false positive? Walk us through this.
Yes, absolutely. So phosphatidylethanol is a biomarker that is now widely available, I think, in pretty much every lab, and, is indicative of alcohol use. And so this is just a molecular depiction of what occurs. So short chain alcohols actually have a high affinity for phospholipase. So in the presence of ethanol, you have the formation of these molecular species, these phospholipids, such as PEth. There's many different types that we use. And then if you go to the next slide, then we can discuss how actually the degree of elevation of the PEth can also indicate how much someone is drinking. So it can differentiate between, light, moderate, heavy alcohol use. And so with these cutoffs here, you can see that with a level of less than 20, it doesn't mean necessarily that they have had zero alcohol, but that it is a very, very low amount, considered to be low risk alcohol use. And then that moderate area, which is 20 to 200, which is about 2 to 4 drinks per day, several days of the week, which is considered moderate alcohol use. And then heavy use is over 200, which indicates more than 4 drinks per day, several days of the week. And this is considered high risk alcohol use. So the degree of elevation can help indicate how much alcohol they're drinking.
So, Jesseline, she's claiming false positive. Do you see false positive PET tests? Do you disagree? Or could this be mouthwash? Listerine? I don't know.
That is a great question. I'm glad that it wasn't a borderline level because I feel like those are much more challenging. So I think
patient last week, and the addiction medicine doctor swore that PET of 288 was a false positive due to chronic liver disease.
I have not heard that before, but Maya's is 480. So, that's, I think that would be very hard to say that's false positive. So actually, with PET testing, it has that's 100% specificity, almost just as high sensitivity. So it's a very, very good test. There was a good question yesterday at one of the sessions from Dr. Brian Lee about blood transfusions. This is something that we are running into quite a bit, and especially our very sick cirrhotic patients. With her, I will say that I don't know how that would be a false positive result. I think that's accurate, and she's drinking a lot more than she's reporting.
So it's a very accurate test and that test.
Very accurate.
And hers is 488. So that's really high. Okay.
High risk.
For better or worse, transit esophagus has become an extension of our examination. And we're using it in more and more settings besides hepatitis C and MASH, we're in PBC now. Pierre, can you walk us through what this 21 means to us? I mean, should we put on the transplant list? Should we talk about endoscopy? What do we do?
Sure. Yeah. I mean, clearly our ability to non-invasively diagnose clinically significant portal hypertension has been greatly enhanced by the Baveno 7 criteria for rule in and rule out. I will preface this by saying that Baveno 8 happens in exactly 4 weeks from now, and our portal hypertension benevolent overlords may actually add additional criteria to what determines a better rule in and rule out, which I suspect will be dual cutoff reporting with spleen stiffness measurement. I don't want to talk about this too much, but I will say that if you own a 630 machine and have spleen stiffness capability at your institution, you would have been by now very much humbled by your limited ability to perform a decent ultrasound on a patient and localize the spleen. So our European colleagues definitely have an edge on us in their ability to implement this. But briefly, a spleen stiffness cutoff of 50 or 45, depending on who you believe, in almost any clinical setting is a very, very strong predictor of CSPH. And a spleen stiffness measurement with a dual cutoff in the same range for liver stiffness measurement pretty much essentially rules it out. What we have as of the Baveno 7 are very good criteria to rule out based on single cutoff reporting. And so if your liver stiffness measurement is less than 10 kPa, you can pretty much take it to the bank that the person is very unlikely to have CSPH. If they have a spleen stiffness greater than 20, you are very likely to have CSPH, and certainly if it's greater than 25, you have essentially ruled it in. There is that gray zone between 10 and 20 where platelet count plays an important role, and certainly if your platelet count is less than 15 kPa and your platelet count is less than 15 kPa and your spleen stiffness is 15 or more, you can also be fairly confident that the patient likely has CSPH. If it's under that cutoff, this essentially rules out what they refer to now as VNTs, varices needing therapy. Okay. So I think that's a blueprint for where we are today and where we might be heading in 4 weeks from now.
Yeah. So what do you do with the results? Do you start on carvedilol? You do an upper endoscopy? How does that change your management?
So I think the biggest implication, and I'm sure many colleagues in the audience will resonate with them, is I now rarely do so-called screening for esophageal varices anymore. I don't need to do that based on a non-invasive assessment of whether you have the presence, not of varices, but specifically VNTs, varices needing therapy or not. I think that is the most tangible impact of Baveno 7, and I suspect also Baveno 8.
Would it change if I told your plate count was 84,000 in terms of endoscopy screening?
So if your platelet count is less than 150,000 and you have a liver stiffness measurement greater than 15 kPa, your risk of having varices needing treatment is high, and you will probably do an endoscopy at that point. Right.
Jasleen, Avish, how do you guys use this in your practice? Do you guys start beta blockers? Do you go first for endoscopy?
Yeah, absolutely. I think with a liver stiffness measurement that's elevated over 20 with low platelets, I am going to just straight starting people on non-selective beta blockers. One thing is that, and I do think this is like a, maybe a more archaic form than what we're doing now. I do actually do a lot of screening endoscopies. I think with non-selective beta blocker use, I don't think people are very adherent to it. Some people can get very symptomatic. They might, be taking a very low dose, not enough to actually reduce the portal hypertension to a degree where they might potentially need varices that need therapy. So I am still doing some screening endoscopies in select cases.
Avash, how about you?
Yeah, I think that I often do a one-time screening endoscopy in these patients that I'm concerned about clinically significant portal hypertension for, but then I have a very low threshold at that point to start non-selective beta blockades for primary prophylaxis. I guess one of my questions with this case is how much we think potentially the inflammation ongoing inflammation could be contributing to this patient's stiffness of their liver and how accurate we feel about the stiffness level. So is this a case where we can confidently say that this patient, based off the platelets, has clinically significant portal hypertension, or is this someone that we potentially start to put on therapy, ask her to stop drinking, and then reassess a liver stiffness at that point to make a new staging?
I will say one more thing about the issue of endoscopy. I think the Predici trial very much changed the calculus in terms of the decision-making process as to whether to initiate specifically carvedilol, not just a non-cardioselective beta blocker, because there clearly is a signal for a survival benefit above and beyond reducing risk of variceal bleeding or dying from variceal bleeding. So it is almost a moot point in many of these patients as to whether you actually change your decision-making based on whether the patient has varices needing treatment or not. That's been my practice, at least.
You know, one thing I just realized, we kind of gloss over the PET test. So it's pretty high. So in Justine, if this lady came to our office, and, you know, with the diagnosis of autoimmune hepatitis, and the PET is now 488, what do you do? What do you do with the PET test?
Yeah, absolutely. So, she clearly is drinking quite heavily and with a binge drinking pattern. With having a concomitant underlying liver disease, she's at risk of progressing quite rapidly. And it seems, based on liver stiffness measurement and low platelets, that may be the case. So, of course, I would counsel on complete alcohol cessation. In my practice, I do offer medications for AUD therapy. So, either naltrexone or acamprosate for her, at least offering that. And then, of course, offering an addiction medicine referral. But I absolutely agree. I think addressing her alcohol use is just as important as the autoimmune hepatitis.
Pierre, how about you? How quickly do you get addiction medicine involved?
I offer MAUDs to all patients with an alcohol use disorder, including patients with cirrhosis. And I might add, there's pretty good evidence now that suggests that even in patients who have decomp cirrhosis, these medications are quite safe, although the label might argue otherwise. My go-to is naltrexone, and 90% of my patients get naltrexone. I used to be a gabapentin fan, but I think the evidence for naltrexone is better, and that is standard fare if you have an alcohol use disorder. I also offer patients cognitive behavioral therapy and a referral to someone who can help with this, because that obviously enhances their ability to prevent return to drinking.
Avash, in your practice in New York?
Yeah, I have a comfort level now prescribing naltrexone, and that's usually my go-to, or acamprosate,
Okay.
based off their creatinine clearance.
So she's 20 years old, about to get married, and Avash asks you, can I have a baby? Now she's got cirrhosis, portal hypertension, has autoimmune liver disease. How do you counsel people about reproduction?
Yeah, so I think one of the biggest things I would tell her is how important adherence is right now, how important it is to control her autoimmune hepatitis as well as possible, because we know the best thing that we can do for our patients that might get pregnant is controlling their autoimmune hepatitis, getting it into remission for as long as possible before potential conception. So that would be something that we spent a lot of time talking about. I think it's really important to have these conversations as early as possible. And then I guess that it's unclear what medication this patient is on, but if this patient was started on mycophenolate, then obviously this is a medication that needs to be stopped before conception, at least 12 weeks before conception. So I would think about actually transitioning this patient to another medication if they're already on mycophenolate. And so this would be someone who I would start talking about transitioning from mycophenolate to potentially azathioprine to get her into remission going into a pregnancy. And then I would once again talk about this risk of post-delivery flares and just educate her on how we need to keep a very close eye on things afterwards. And this is just from the practice guidelines on reproductive health that goes over the different medications, but just highlights how mycophenolate is contraindicated. And then we just don't have enough data on mTORs, which is obviously not a first line agent for these patients, but something.
I guess go back to the idea of alcoholism in someone who's pregnant, infant injury, et cetera.
Yeah, so definitely emphasizing that from the very beginning.
So I want to leave a few, I think that's it. I want to leave a few minutes. Any questions from the audience to our distinguished panel on autoimmune liver disease and CSPH? Yes, ma'am.
It's a quick question.
PET test you all do differently. Do you get consent or do you tell them?
Good question. Good question.
I do not ask, but I do tell. So I say I'm going to check a blood marker that's going to tell me how much alcohol you use. And for me, that's to also give them the opportunity to maybe be more forthcoming if that's an issue. I might not remember to tell everyone, but I think asking permission sets up kind of a difficult dynamic between provider and patient.
So if they say, oh, but I don't drink at all, then what do you do? Because I'm trying to utilize PET for my teen and young adult patients, and I know that's the pushback I'm going to get.
Yes, I think that's a comment that we often actually get, and so then I just check the test. And
You still do the test?
Correct.
Pierre, how about you, or Avash?
Oh, I have a similar approach. I say, hey, these are a set of labs that we order on all of our patients as we evaluate for other causes of liver disease, and one of the things that we test is for this marker of alcohol use. And so, yeah, I don't ask, I tell.
Great question.
Yeah, I mean, I've struggled with this question initially when I started ordering PET, but here's my perspective on this, which I think is largely shared by folks in the field. Checking for alcohol use disorder or the presence of alcohol is actually a part of a standard workup for a patient who has chronic liver disease. It is not in any way an attempt to out the patient or divulge some covert alcohol use disorder in order in any way harm the patient. So what I tell the patient is, we check for causes of chronic liver disease. These include viral hepatitis, autoimmune disease, inherited cholestatic liver disease, and also we check for alcohol exposure. And if patients say, but I don't drink alcohol, we say, it's difficult sometimes to recall what your exact alcohol consumption is. There may be situations where this may not have been entirely assessed, and so it's part of your assessment, and we're going to order it. I don't ask them to sign informed consent. And typically, a patient who, after this conversation, does not show up for their labs is very telling, because that implies the patient chose not to have the workup done. But I don't ask for, we certainly don't have an informed consent process.
Yeah, we've used that strategy for over 18. Under 18, it's still a black box. I don't know what to do. And then also when a patient gets a bill and says, hey,
Right.
I told you I don't drink, and now I've gotten a bill. So, thank you.
Brian?
Thanks. Just 2 points, the naltrexone being contraindicated in your Bs and your Cs, so your decomps probably off-label. So I'd probably be careful about that and naltrexone. The second is the non-selective beta blocker are big, also, we didn't mention, but probably everyone in the audience knows it's prevented for ascites, the first episode of ascites. So worthwhile mentioning, especially if you're not doing endoscopy screening using Bovino 7, and go ahead, that's your best use.
Naltrexone decompensated patients?
This is all accurate, and I will also retort and say that there is now pretty extensive case series, the largest one from the Yale, the West Haven group, that shows that naltrexone is exquisitely safe in people who have decompensated liver disease.
Right, so
I have no problem using it, but I don't endorse using it. If you don't want to use it,
Right.
by all means, don't use
Just
it.
at least
But
be aware
I'm
of
very
it.
comfortable using it.
When we give it in those patients, we're always cautious and tell them it's a risk. So,
Right.
Thank you, Brian.
thank you.
Next.
Just a quick question. So obviously when a person has CSPH, you're starting a non-selective beta blocker, carvedilol. If their elastography is 25, do you still just do the non-selective beta blocker, or do you still screen for varices? That's something that I've struggled with, because the guidelines are kind of wishy-washy, I think, about whether you still need an endoscopy or not.
You're absolutely right. I mean, I'm going to come clean. I rarely, if ever, do endoscopies because Pradici pretty much changed my perspective on this. There is clearly a benefit above and beyond reducing the risk of primary and secondary bleeding. Therefore, what is the point of doing an endoscopy? If the patient bleeds, you can do the endoscopy. But if you are committal to giving them carvedilol, and specifically carvedilol from the get-go, then just do it. And if they bleed, then so I agree with you 100%.
Yeah, I guess it's just my neuroses of wondering, is that enough, right? Is it truly, like, is the 12.5 once a day, is that going to be enough to prevent the bleed? And I
Yeah,
know that there's to suggest that, but, I think a lot of my colleagues still will scope people.
Yeah, and I think one thing about Prodeci as well is that only the patients who had responded to the intravenous non-selective beta blockade were the ones that were included. And so I think I struggle with maybe not everyone responds similarly to carvedilol, and number two, I think I'm finding out that my patients may just be very non-adherent, but they, a lot of them don't take the medications that are prescribed, and I think I feel like I need to do that endoscopy often then.
That's how I feel too. I feel like sometimes the struggle to get these patients into clinic to up-titrate their beta blocker and feel good about the fact that they're actually taking it. So that's sometimes what pushes me to do these endoscopies.
We got to keep on going, because we have only one more minute. Ira, sorry.
Sammy, thank you. Great session. The great hepatologist Jenny Heathcote once said that all young people with the diagnosis of autoimmune hepatitis ought to be screened with an MRCP for sclerosing cholangitis because of the higher incidence, as she then described it, of overlap syndrome in young patients. So I know this isn't a cirrhosis question, it's an AIH question, but it's the same patient, so I got up and asked the question. Do you do it based on ALK-Phos? Do you not do it because the ALK-Phos is normal? What's your cutoff for screening for that? And do you find it a lot, as she and many others have found to be the case in younger patients?
Is the question about AIH,
Overlap
PSC?
syndrome with sclerosing cholangitis.
Right.
Yeah, I will say that that's very rare, so I don't find myself looking for that as often. So if I do suspect overlap, if anything, it's with PBC. So, if I have an ultrasound or some imaging that indicates the ducts look normal, then I might just trial them on ursodiol.
Ira, do you do it?
Yeah, I've got a bunch of patients who are now in their 20s who developed one or the other. More often the AIH first, but it can go either way.
Okay.
Maybe up to half a dozen of those patients, so it's a real phenomenon.
Thank you for sharing.
And yeah.
I undiagnose patients of overlap syndrome far more than I actually diagnose them. I think if you use rigorous criteria, histological criteria above and beyond ALT elevation or lobular inflammation or non-specific things, if you look for the real deal interface hepatitis in the context of another liver disease, overlap syndrome is a fairly rare disease, quite rare disease, and so I typically do not routinely do an MRCP for those
Last
patients.
question, Shoy.
Just a quick question. What's the panel's approach to patients with progressive fibrosis in the setting of normal inflammatory markers? So normal transaminases, normal IgG, you've been monitoring them for a while, stable medications, you do a fibroscan a couple of years after, and there is still progressive fibrosis, no metabolic syndrome, and no fatty liver disease. Do they typically...
Short answer.
Yeah.
So progressive liver disease is by normal liver test.
In autoimmune hepatitis, you mean?
autoimmune
I mean, one of the most depressing papers I ever read was another paper by Al-Jaya that shows that even in people who have prolonged biochemical remission, there is sadly a slow progression of fibrosis over time. I don't know how you address that. I believe that that is indeed true, but above and beyond maintaining biochemical remission, I don't know what else you would do other than monitor the patient. It's a very good point, though.
Thank you. I want to thank our panelists for a great discussion.
Great. So this is the scary part, right? I'd like to invite up to the stage Dr. Gunn, Dr. Kardashian, and Dr. Singh. Hopefully they're all here. Okay. Dr. Gunn is the Chief Medical Officer of Hepatology and Obesity at Iterative Health, and she leads clinical strategy and innovation at that site. She's also the Hepatology Clinic Director at Coriell Health, and is an adjunct assistant professor at Texas A&M. Dr. Kardashian is assistant professor of medicine at USC and a transplant hepatologist, specializing in fatty liver disease, cirrhosis, liver transplantation. And Dr. Ashna Singh, one of my former colleagues, is a practicing hepatologist, assistant professor at Indiana, and she actually specializes in care and research for those with liver disease in pregnancy and women's health. So thank you for all of you joining us. So we're going to continue, these are our disclosures. We're going to continue with the case. So Maya has been following up with you at some interval. She has been continued on carvedilol and MMF, but has reduced her dose to 250 on her own BID. She reported stopping alcohol after college. She states she's compliant with her medications, although she did self-reduce. She's been somewhat erratic in her follow-up, and she reports, hello, I'm 6 weeks pregnant. So I'm sure we have all faced this patient before where you think you're following them, you think you're advising them, and then they show up and tell you something completely new. So here are her updated labs at the time she comes to see you. Transaminases are 38 and 40. Her bilirubin is 1.3. Alk Phos is 121. Albumin is still intact, 3.8. Her white count is 6,500. Hemoglobin is good. Her platelet count is reduced, 140. She has an IgG of 1450. You do a PEth, and it is negative. She has a FibroScan, and she has a liver stiffness measure of 21. So we're going to talk about this case now, because this is a challenge, right? Whenever somebody shows up pregnant in my clinic, I'm very fearful. So this patient comes to you now pregnant, and sort of just to start off by discussing, what are some of the major clinical concerns that you have in a patient? She has very advanced liver disease. She's compensated at this point, but clearly now is going to go changes. So Ani, we'll start with you.
Yeah, I think there are kind of two big issues we need to sort of think about with this patient. One is her autoimmune hepatitis and managing that during her pregnancy. And then the other issue is her cirrhosis and managing her cirrhosis in her pregnancy. With regards to, I think we'll talk a little bit more about this with her autoimmune hepatitis, but I mostly want to make sure with that regard that my patients are in remission and well controlled. Their disease is well controlled prior to pregnancy. And I tell my patients I want them to be in remission for at least a year prior to getting to conceiving. And that's because outcomes are better, maternal outcomes and fetal outcomes are better if the disease is better controlled. So there are higher rates of pregnancy loss, stillbirth, and miscarriage among women who have uncontrolled or poorly controlled autoimmune hepatitis or who are flaring during their pregnancies, as well as higher rates of preterm labor. And then for the mom, higher risk of maternal gestational diabetes. So again, just better to be well controlled ideally prior to conception. The other issue is just management of her cirrhosis. So the thing, I think about in pregnancy is that a lot of the physiologic changes that occur in pregnancy mimic those of cirrhosis. So the hyperdynamic state, the increase in plasma blood volume, which can be as high as 40 to 50% by the third trimester, but does go up rapidly in the second trimester to 20 to 30% of baseline. So kind of important to know that the complications of cirrhosis, including the development of portal hypertension, get exacerbated in pregnancy. So those are kind of the two things that I'm thinking about. And then, of course, obviously her medication management as well with autoimmune hepatitis that we'll get into.
So you talked a little bit about some of the hemodynamic changes. Ashna, changes in blood volume, how do you assess that in a patient, like in terms of risk? And how do you counsel them?
Well, first off, I'd like to say this is a nightmare fuel kind of patient. Unfortunately, these are the ones we do see. The physiology in pregnancy in general can mimic many of the changes we see in decompensated cirrhosis. So in pregnancy in particular, in a patient who already has, we're going to assume not overt, but clinically significant portal hypertension, you will see a 30 to 50% increase in plasma blood volume over the course of the pregnancy. Cardiac output increases significantly, really up until the end of second trimester. And then by the end of second trimester, you have a uterus that is so large that it does compress the IVC, and then you have an increased reason for portal hypertension. So blood flow and volume, the IVC being compressed, and just the progression of increased cardiac output all increases it. So I will, in a patient like this, we have an LSM, we have imaging. I'm going to assume that she has portal hypertension that will progress as her pregnancy progresses. This is someone that, my first visit, we talk about definitely we're stopping the MMF, and the hope is that she doesn't miscarry because there's such a high risk when they're on MMF to begin with, and they get pregnant of miscarriage within the first trimester. But with the hope she doesn't miscarry, we're going to stop that. We are absolutely going to talk about endoscopy in second trimester. That has to happen. And then she's already on a non-selective beta blocker. There is, the EASL guidelines say that there is limited data, but okay to use carvedilol in pregnancy. Depending on the institution you're at in the US, there's a little bit more reticence to use carvedilol. So there is some switching over to propranolol. And so that may be a conversation to have. And if you know the comfortability of your MFM team and your OB team at your institution, that's something that you can kind of flesh out. But those would be like the three main things we talk about at that first visit.
And Nadej, what do you think about in terms of the risk of flare during pregnancy, postpartum? What, you're trying to think through this patient as she travels through her pregnancy.
Okay, there's a very real risk of flare, but before I go there, how many of you in the audience are comfortable with pregnancy and cirrhosis, just by a show of hands? Okay, 3 people raise their hands. So that's what I want to echo. I'm a hepatologist, rural community. This is the exception rather than the rule. So number one, and it was mentioned earlier, but we really have to have that heart-to-heart conversations with women, childbearing potential, about what kind of contraception are you using? When do you plan on becoming pregnant? We do want to make sure that your disease is controlled at least a good full year before you attempt pregnancy. The types of contraception, IUD, progestin-containing oral contraception versus an estrogen-containing one, which may increase their risk for thrombus. These are the kind of things. And nutritional status, remember, prenatal vitamins, ensuring that these individuals are nourished, because now the pregnancy and the cirrhosis may drive issues with their nourishment. But as far as flare, to your question, that may be more an issue if the disease wasn't controlled initially, the shorter duration of therapy, and of course, or no therapy at all could increase risk during the pregnancy. Now, pregnancy itself is a tolerant time where there is more anti-inflammatory processes over pro-inflammatory, but it is that postpartum period that we really worry about, because now the mother's defenses are gone, that tolerance is gone, and now that flare could be even more likely. So we want to make sure the disease is controlled ahead of time, during, and then really following closely postpartum.
Yeah, I think that's a really important point. Obviously, we've described a patient, and many of my autoimmune patients, they go away, they come back. Sometimes I realize I haven't seen them for 2 years. They do kind of what they want to do. The younger they are, the worse it is. So somebody mentioned upper endoscopy. We're always, terrified to do any procedure in a patient who is pregnant. So Ani, what about endoscopy? This patient comes, she's got a KPA of 21. She's pregnant. What do you do?
Yeah, so I was already kind of previously alluded to, but ideally, these patients would have had an endoscopy, within the year prior to conception. So that's sort of the ideal scenario. So if you have a woman of childbearing age, they're talking about getting pregnant or it's on the horizon, I actually do like to do the endoscopy prior. That would be the preference. And then if they have small varices on that endoscopy, I'll start a non-selective beta blocker if they're not already on one. And then if they have medium or large varices, you can go either way with primary prophylaxis, although I tend to band and be aggressive, particularly if I know they're going to be getting, pregnant. If they're already pregnant and then they're coming and seeing you, if they have not had a recent endoscopy, then I do it at the beginning of the second trimester. And I do it. So as already mentioned, the expectation is that their portal hypertension is only going to worsen during pregnancy. So all women should be, pregnant women who haven't had a recent endoscopy should get one in the beginning of their second trimester. And then if they have small varices, I start a non-selective beta blocker. Medium or large, again, you can go either way, but if there's anything that's high risk, I will ban them.
So Ashna, just to follow up, we just heard a lot about Ravino, and these guidelines were written before you know, the most recent Bravino, would you ever use Bravino in lieu of an EGD to determine whether you needed endoscopy?
Using FibroScan or
using FibroScan platelet count as opposed to just as recommended doing an EGD within the prior year or during the second trimester?
So the problem with that I have noticed clinically with using FibroScan, right? You know that even you take a patient without liver disease and you check of an LSM during pregnancy, as it progresses, it will be higher. And so, especially in this scenario where I know she has chronic liver disease and likely, you know, advanced liver disease with some signs of portal hypertension, I would not use it. So I would definitely just opt for the EGD. I say that easily, but it is a very tricky scenario. At most institutions, you're not going to do this at an ambulatory endoscopy center. This is going to be attached to the hospital. It will require an OB, likely an OB anesthesia consult. If you don't have OB anesthesia, then it will require an anesthesia consult pre-procedure, in addition to coordinating with L&D triage and making sure that there is baby monitors available pre and post endoscopy. You know, so it is a tricky procedure, but this is something we would do, and FibroScan as a substitute just does not cut it for this scenario.
So Nadesh, we talked a little bit about beta blockers. Most of these patients, if we know they have portal hypertension, they're going to be on carvedilol. Is carvedilol safe in pregnancy? Would you switch to propranolol or another beta blocker?
So that's been a question that comes up quite often. And as a class, beta blockers are safe. We've learned this in the hypertensive emergencies or considerations in pregnancy with labetalol as an example. So the guidelines are suggesting that if the beta blocker is appropriate for your patient, carvedilol or propranolol are appropriate, and yes, I would continue it. And I'm seeing more in the guidelines regarding the endoscopy that it should be done within that first year, and if it hasn't been done, to try to get it within that early second trimester.
All right, so we've talked a lot about azathioprine and MMF. Just as an aside, I use MMF almost exclusively in my patients. Again, there are implications for a young individual of reproductive age, right? So routinely, if you have a patient of reproductive age, azathioprine, MMF, one or the other, counseling, what do you guys do? Ani?
Well, I favor azathioprine just because we'll never forget, I had a patient who was on MMF, and she told me she was using contraception, and then she got pregnant and unfortunately miscarried. And so those few cases often stick in your mind and you don't forget. So I try as best as I can to have my young women of reproductive age on azathioprine. If they require MMF for whatever reason, I do recommend two forms of contraception. So, an IUD or oral contraceptives and condoms, for example. But again, I really try, if I can, to have them on azathioprine just so that we don't get into that issue.
We didn't really talk about this, but the opportunity for pregnancy in a patient with advanced liver disease. I have patients who come in, they don't have a regular menses, they assume they can't get pregnant, so they don't use contraception. Ashna, what do you advise to your patients?
Yeah, so it's a common misconception that patients with advanced liver disease cirrhosis may not be able to get pregnant. Many times, I think earlier on in the meeting, there were some questions about, do you ever ask about menstrual cycles in the clinic visit? We obviously all do, because this is our focus, but one of the important, patient education points is even if you're not having menstruation regularly, you likely still are ovulating. And so the risk of pregnancy is there. So if it is desired, that is one thing. And then we have that preconception counseling visit and we talk about all the risks. But if it is not desired, there are many safe options for contraception use. Progestin only, most of the oral estrogen containing OCPs now are very low estrogen. So, usually very safe in patients, especially with compensated cirrhosis. And so we have that conversation at the get-go. And then, I typically won't even broach MMF in patients of reproductive age unless they've had a sterilizing hysterectomy or they have told me that there's just no chance they are, they are not going to get pregnant. This is not a desire. They are celibate. That's a different scenario, but I will avoid it. Even post-transplant and patients who are within that first year, if there's a thought that they may become pregnant, we switch over to AZA.
Oh, sorry. I just had a question to you ladies. How would you approach the transition from the MMF that this patient is on while she's pregnant, and are you afraid?
Yeah, I would. So immediately stop MMF. Her liver tests were mildly abnormal from what I call. And so we would start prednisone. Prednisone is completely safe in pregnancy. Old data had, initially brought up cleft abnormalities, especially when taken in the first trimester. That does not pan out with the new studies. And so completely safe to use in pregnancy. I would start likely a healthy dose of prednisone and then get her, if she's had TPMT testing, would test that. And once that comes back normal, start her on azathioprine and then eventually transition off steroids.
I think that's a really important point in terms of, the second somebody is pregnant on MMF, right? Fetal loss is going to be very high, as you suggested. Probably 50% are going to spontaneously abort, but certainly stopping immediately. Nadej, monitoring. Okay, so you have a patient who has a diagnosis of autoimmune hepatitis. They're pregnant. You see their baseline liver tests. How frequently would you monitor them? I'm assuming you're going to monitor them with an, maternal fetal medicine expert, somebody who knows more about pregnancy than I do. But what would you? Are you going to, monitor these patients more frequently? What do you do?
Yes, just simply because I'm afraid. I probably keep them very close to the vest, probably every couple of months, just to make sure I'm not missing anything, and also ensuring that the multidisciplinary team is tight and that we have communication flow between OB, MFM, and any other specialist that may be aware of this patient. Could be anesthesia even, in preparation for the delivery and how that might go. So we want to just make sure that the follow-up is tight. We're checking the same labs that we would do on any other person with cirrhosis and autoimmune hepatitis, but just with a close knit of specialist friends around.
Ani, if the patient had not been recently imaged, would you image the patient at the beginning of pregnancy? And if so, what would you use?
That's a great question. If they hadn't been, if they haven't had any kind of, recent, the only thing I could think is if they need kind of liver cancer screening and they haven't had anything done recently, I guess I would probably consider doing an ultrasound for that. Ultrasounds are safe in pregnancy, so that you could do. Others, CT scans, ideally you try to wait till the second trimester, just when the risk of ionizing radiation to the fetus is lower. MRIs are actually, okay, but gadolinium is not. Gadolinium is teratogenic, so that has to be avoided, but you certainly could, if you need it for any reason, or MRCP, a woman had developed stones, you can do that. But I guess if they hadn't had anything very recently, I would consider the ultrasound. But otherwise, I don't necessarily image them during the pregnancy. Curious about what others would do.
The question is really whether you would image a patient who had not had recent imaging, maybe looking for adenomas, or in this patient, I guess, malignancy as well. But
Right. So if a lot of times patients come to my clinic for the first time with, whether it's the first time they've known that they have a liver disease and then now they're pregnant, and so I do still put them through that testing. And so just like you said, risk for adenomas, and I would like to know if there is an HCC lurking or anything like that, because then we have more to talk about with the pregnancy. like Nadij said, we keep these patients close. I think there are very many good considerations to either have maternal fetal medicine and hepatology combined clinics or to stack visits, right? These patients are going to see MFM. They're going to frequently be touching base in healthcare facilities. And so I will often couch it as we're going to do your ultrasound at the same time as your first, fetal ultrasound or your fetal echocardiogram or whatnot. And I will couple those together. And so it's not as burdensome. And then also, I follow them with each trimester. I typically will offer virtual after that first visit so that, I know they're seeing their OB or their MFM physically often, sometimes weekly at the end of pregnancy. And so just a way to kind of keep them engaged and adherent with follow-up.
So Nadej, there are laboratory changes that occur naturally in pregnancy. Let's say the patient comes to you pregnant, depending on the trimester, liver tests are elevated. She has a history of autoimmune. What are you thinking? How do you sort it out?
Well, that's a very good question. That's part of the reason why it's important to keep a close follow-up with the patients, because as you know, in pregnancy, the alkaline phosphatase may go up. The AFP actually may also be higher. And as we're monitoring for HCC and things that might trigger, what's going on here? Albumin may be lower as the pregnancy progresses and there's more dilution there. So these are things that by keeping a close cadence on your monitoring, you can see the trends, and high values may not be as surprising as it would if you haven't been monitoring.
And I guess the one thing.
Yeah, Ani, just to follow up on that, LFTs go up.
Right. I was going to say, the one thing I'd add to that is, the AST, the ALT, the bilirubin, those should not go up in pregnancy. So if any of those do go up, I think her bilirubin was just ever so slightly elevated. It was 1.3. So if maybe I think that's more consistent with her baseline. But if you see an elevation in the bilirubin, beyond that, or the AST and the ALT, those are not normal in pregnancy. So that's where that would alert me to, is she flaring? What else might be going on? Do we need to do a workup? Should we check viral hepatitis serologies? So that's where I would kind of take a step back and then think about doing an additional workup.
All right, pre and post-term labor considerations. Ashna, I'm going to go to you because you've dealt with this before. And as part of it, I think one of the question is vaginal delivery C-section. What do you recommend?
Yeah, so preconception counseling, first and foremost. Obviously, in this scenario, it didn't happen, but that would be the first thing that we always try to make sure happens. Always prefer vaginal delivery in especially patients with advanced liver disease. Many community OBs and some anesthesiologists get very nervous about vaginal deliveries in patients with cirrhosis. The reason being, obviously, labor, that vagal maneuver can increase portal pressures, and there's risk for variceal bleeds at that time. But if we have done all these things, we've done that second trimester EGD, we have put them on a non-selective beta blocker if they need, and we have kind of mitigated the risks as much as we can. My advice always to OB is that if we're, the goal is vaginal delivery, we are going to avoid a short, we do not want a prolonged second stage of labor. I do not want her pushing for hours and hours. So if that is the scenario, then C-section is preferred. But that's really the only scenario that is a consideration. Otherwise, elective C-section, I am not for in these patients. I don't know about the rest of the panel.
Right. As far as C-section is concerned, I know that there's some considerations you may want to make ahead, especially someone who has cirrhosis, potentially portal hypertension, to make sure maybe some imaging was done for collaterals or abdominal varices, so that is not an issue when they have the operation. The other thing is a C-section is an abdominal operation, and then there's this real risk for potential post-operative ascites. So all the more reason to hope for a vaginal delivery and maybe an assisted second stage with a vacuum forceps or what have you. But you're not going to tell an OB how to do their job. So.
Great. That's been a great discussion. We have a couple minutes for questions from the audience.
Great session. How do you follow patients postpartum, where there's a risk of flares? How often do you get liver enzymes and for how long?
Yeah, so postpartum, which I call the fourth trimester, is a very important time period for these patients that we cannot lose touch with. You still have actually, so autoimmune hepatitis in particular carries an increased risk of preeclampsia and HELP. That can still extend into the fourth trimester. And so many times we can be fooled in thinking that they're having an autoimmune hepatitis flare, but it really is one of these, liver or pregnancy-specific liver disorders. So that fourth trimester, very high risk for autoimmune hepatitis flare. You can still have lingering effects of preeclampsia and HELP. And so very important to get them in, even if you can't physically see them, getting them to do routine labs very quickly after, touching base with OB who will see them very, very quickly after, making sure that that is done. And so depending on what immunosuppression is used during pregnancy, that is another time that you may have to really increase or cut back on immunosuppression. So patients of mine who are on tacrolimus during pregnancy, that plasma volume drops immediately after in the postpartum setting, and that tacro level will go sky high if I don't, cut back right away. So there's lots of considerations, and our work is not done in that fourth trimester.
Great. Yeah.
Great session. Quick question. Can you clarify about transition from MMF to Imuran, because Imuran is very slow acting. So in a patient who's in remission, do you overlap or what do you do? I worry transitioning in flare when you transition.
If someone's in remission, I don't, if I'm switching them from azathioprine, you're saying from azathioprine to, from MMF to azathioprine?
Say if the patient say, I want to be pregnant this year, so you want to transition.
Oh, transition, switch it up. I don't always, if they're in remission, I don't necessarily steroid bridge them. I will stop the MMF and then start the azathioprine, but I will monitor their labs very, very closely. So I'll, check their labs every, 2 weeks, and keep an, obviously if, the liver test changed, then I would have a low threshold for potentially starting steroids, as I'm up titrating the azathioprine, but I don't necessarily, bridge, and I don't overlap either.
Have you ever overlapped the two?
I don't do that. I don't know if others do, but I've never kind of in my practice overlapped. Yeah, I haven't done that.
And it's also not unreasonable in the postpartum state to revert back to what was controlling the disease before pregnancy. But of course, with the caveat of monitoring, especially if the woman's going to be breastfeeding, knowing what the drug interactions could be or potential complications with breastfeeding. And if there aren't any, then you can consider just getting them back to what they were so that you can not bite that bullet.
I will put the disclaimer out there that mycophenolate has not been studied in lactation. And so I do not put people who are wanting to breastfeed or actively lactating on mycophenolate after transplant. So important for post-transplant patients, but also other difficult to control autoimmune hepatitis patients that you might want to revert back to MMF if that is contraindicated in breastfeeding.
I think we have time for one more question and a quick answer.
Okay. Well, first off, fantastic session, very informative, very high yield. So thanks to all of you. I have a question that may or may not make sense, but I had a patient who had well-preserved synthetic function, but had significant fluid overload, no ascites, and I was dealing with an issue with diuretic management. And the OB was concerned about the spironolactone having some type of androgenic effects on the fetus. So I was curious about what your thoughts were on diuretic management in the pregnancy phase.
So I have part of my pregnancy clinic. I also have a ton of Fontan-associated liver disease patients who are in various stages of compensation or decompensation. So many of them come on board with diuretics. So we don't encourage the use of aldactone if possible, especially not in the level, the doses that we typically use in decompensated cirrhosis, which is, well over 100, 150, 200. So it typically is a Lasix-based diuretic regimen. I do the same thing when some of my cirrhotic patients decompensate in pregnancy. I typically really will only use Lasix with potassium.
Thank you.
We're going to finish with sections 4 and 5 of this case. And then Dr. Brown is going to wrap up this meeting for us, and I look forward to her telling me all the important stuff that I may or may not have noticed throughout these last 2.5 days that, sort of in my biased opinion, have been great. So let's move forward. Over the next half hour, we're going to keep on talking about Maya. Let me invite my panelists. First, Dr. Lauren Nephew. Dr. Nephew is an assistant professor of medicine and associate vice chair of health impact at Indiana University. Fantastic football season, guys. She specializes in liver disease and researches health disparities and access to care. Next, I'd like to invite Dr. Robert Rahimi. There he is. Who's an assistant professor of medicine and who's a board-certified gastroenterologist and a hepatologist at Baylor Scott and White Health in Dallas, Texas. He's an associate professor at Texas A&M College of Medicine, specializes in liver and digestive diseases, including chronic liver disease, fatty liver, portal hypertension, and complications of cirrhosis. And last but never least, Dr. Mitch Schiffman, who is director of the Liver Institute of Virginia at Bon Secours Mercy Health in Richmond, Virginia. He specializes in liver disease and transplantation and leads clinical care, research, and education, and has been trying, partially successful, to educate me for the last 30 years or so. Thank you all for being here, and let's keep the conversation going. These are our disclosures. So now Maya is 2 years after the delivery, and the baby is just gorgeous. But Maya's back on MMF, 1 gram BID, has tapered off her steroids. These are her labs at this time. Her ALT is 38 and her AST is 50, and we don't like when the AST is greater than the ALT. The total bilirubin is now in the abnormal range at 1.3, alk phos a little bit elevated at 121. Albumin is keeping on going down from 4 to 3.8 to now 3.7. White blood cell count, hemoglobin are unchanged, and the platelet count is definitely going down at 130,000. Her IgG is in the normal range. She continues to drink alcohol. And at this point in time, it really doesn't matter, really, if her PEth is more or less than 200, the woman has cirrhosis with clinically significant portal hypertension. Her AFP is 5, and her liver stiffness measurement is 21 at this point in time. So we sent her for another liver ultrasound, and she does not have any suspicious mass per the radiologist. She continues to have a nodular liver surface. Now her portal vein is distended, the umbilical vein is recanalized, and she has a thickened gallbladder wall without stones. I was thinking in the last part of the case that she would be like a great candidate to develop gallstone problems during pregnancy, given the high risk of cirrhosis and portal hypertension. So let me start with Dr. Nephew. How do you do surveillance for hepatocellular carcinoma in your practice?
So in my practice, in general, in most patients, I'm able to follow our kind of standard ASLD guidelines, which is ultrasound-based imaging with AFP every 6 months. I do practice in Indiana, and we are the only academic hepatology center in the state. Many of our patients are also coming from all over the state. So we have many patients, though, who get those ultrasounds done outside of our healthcare system. And so while ultrasound and AFP is in general what I use, it also depends a bit on the patient and the center where they're going to get the ultrasound. So if I've got a patient with a lot of central adiposity, a lot of steatosis in the liver, they're getting an ultrasound done outside of an IU system, someplace where they're not reporting a visualization score, then sometimes I get a little bit anxious and I consider potentially some other type of modality for imaging. But in general, at IU, we do have visualization scores that are reported, so I'm able to kind of rely on ultrasound and AFP. But I do consider sometimes going to a different modality in my patients who have risk factors for having poor visualization, who are getting studies done at places that don't report a visualization, or who I'm afraid that they're going to be lost to follow-up and I'm only going to get one image in a year.
Dr. Rahimi, what do you have to add to that?
I agree. I do the same thing. But what's amazing is her BMI stayed 22 for like 8 years. So the reason that's important because of I know, right? So that was amazing. So that's important because if they have more adipose tissue, fatty liver disease, we've talked about it during the sessions, then it becomes harder to look at ultrasound. So because she's in good shape, I would stick with the ultrasound and AFP in her specific case.
Mitch, sometimes our radiologists insist, or our liver transplant colleagues insist that CT or MRI is better and that we should just forget the ultrasound. Or, sometimes radiology is not very good, or the radiologists see so many things that we need to follow up with more significant testing. Does that make you change compared to what we discussed so far?
No, it actually doesn't unless the patient is already listed for transplant, and then the transplant center will usually alternate MRIs and ultrasounds. That doesn't really make a lot of sense to me. If you're going to do MRIs, you should just do MRIs every 6 months rather than alternate. But in general practice, I think ultrasound is a good screening test, and generally you're not going to miss anything that's a significant lesion. You could argue that you're going to miss a 1.5 centimeter lesion that you could pick up on MRI, but are you really going to do anything about that in a cirrhotic patient who's young, who would eventually need a transplant? You'll probably end up letting it grow to 2 centimeters anyway. So I think ultrasound is perfectly fine. What I do, however, is I do broaden my my serum liver cancer markers. And instead of getting AFP, I get the whole GALAD package of AFP L3 and DCP, calculate the GALAD score for risk. Oh, which is the next thing.
Exactly. Yes. Tell me more about that. Tell me how does that enhance your surveillance?
So basically, not all, as we all know, not all tumors make AFP. And the AFP L3 subfraction is much more specific for liver cancer. And so you can have a low ALP, but if the L3% is significantly higher, particularly if you're following these sequentially and you see the L3% go up, or you suddenly see the DCP go up, that would trigger me to do the next imaging as MRI rather than as an ultrasound.
Lauren, you've done some work in this field.
Yeah, we currently are a site for the National Liver Cancer screening trial for Tracer for GALAD. And so we are, currently randomizing patients to either ultrasound plus AFP or GALAD alone, with the hopes that one day we'll eventually get to a screening modality that is, fully blood-based, increase access for patients for routine screening. Currently, we aren't there yet. So I agree. I do often use GALAD in addition to ultrasound at this point, because I don't think we're at a place where we can do GALAD alone. The times that I will add a GALAD on are often when I have a visualization score of B. So I have an A, I feel comfortable. I've got a good, clear ultrasound. If I have a C, I know I'm moving that patient over to CT or abbreviated MRI if I can get it. If I have a B, I don't really know what to do. I'm like, oh, okay, maybe it wasn't perfect. So that may be someone who I consider adding a GALAD on to their ultrasound, just to kind of see if I have anything that may push me to make that ultrasound next time a CT.
So I am using GALLOT as a kind of risk stratifier in cases that are a bit indeterminate, or if I have a patient who just won't come in for imaging and I can get them in for a lab while they're at that visit. I feel like a GALLOT is kind of better than no imaging alone. So we are kind of using the markers in those sense, but in that sense, until we get kind of evidence from the tracer study that we can use it alone, which we all hope that that's the case.
Excellent. Robert, anything to add? Any other biomarkers that you all three are interested in that may be coming down the pike?
I think you hit the nail on the head, and we use those biomarkers in specific cases, as you discussed, and Mitch also discussed that. And Nicole Rich will probably talk about some other things coming up in the next session. But for me, for this specific case, I would stick with, because she's low risk, the AFP, and if she had some other issues, which the ultrasound doesn't show ascites, or even though she has clinically significant portal hypertension, I personally would not do the DCP in this case. But that's just my practice.
I agree. In this case, I don't think there's a real role for it in this case. And you just probably end up muddying the water.
Yeah, exactly. Yeah.
We touched a little bit on.
We ask about other biomarkers. So there's genetic biomarkers now for liver cancer. One is FDA approved. The other is finishing its phase 3 clinical trial. The one that's FDA approved is a heliogenetics methyl DNA assay, which in their clinical trial demonstrated that they could detect liver cancers that were not seen by ultrasound, particularly the small ones. When you got into greater than 2 centimeters, they were actually fairly equal. Greater than 2 centimeters, definitely equal, but on the smaller lesions. And then Precision Genetics with their OncoGuard HCC test is doing the exact same clinical trial, which we were part of that, and that's kind of wrapping up. So I would ask, do you use them? And the companies, they want you to use them for screening. I have a different idea, but I'd like to hear your idea.
I can't say that I'm using any of the methylated DNA tests yet as screening alone or even as an adjunct. The GALLOT is really easy. It's a lab test. I can order it. It's right in Cerner. It's not even a send out for us anymore. So I can't say I'm using. Now, we were a site for Exact Science, so we used it in a clinical trial setting, but I can't say that myself personally, that I'm actually using it. And it's honestly for probably just really the ease of access. For me, I can reach at a GALLOT, get a similar sensitivity, from what I've read to some of the methylated DNA tests, and it's just easier, quicker, and cheaper.
Yeah, I agree. I don't use it personally right now, but probably that is going to be the future. The companies obviously want you to use it. But I'll ask Mitch, so would you in this specific case, would you use it?
No, I actually don't use them as screening. I use them as tiebreakers. So when I see a lesion and it's kind of equivocal and they're kind of giving you a LIRADS 4, or they're describing, and maybe they say it's LIRADS 5, and you read the description or you look at it and say, that's not a 5, that's like a 3, because it doesn't have all the features. Or you have what you think is an adenoma and you're worried about it. I kind of use it as a tiebreaker to see if it's positive or negative. Obviously, if it's positive, I'm going to be, I'm going to consider that a liver cancer. And then some lesions, particularly that, if the AFP is normal and they're reading out a LIRADS 5, and if either Helio or the OncoGuard test comes back positive, then we would consider that a liver cancer and just move forward.
Maybe I'll add that unless you're considering changing the management, you could potentially just follow up the imaging and see the biologic behavior of that small lesion and see if it grows or not at a period of 3 to 6.
Yeah, I would do that with a small lesion, but a bigger lesion, if your AFP is smaller, where your AFP is normal and you don't know, you're left with, do you biopsy the lesion or continue to watch it? So I think in that sense, that's where these markers are going to have their best utilization.
And all three of you feel comfortable using ultrasound as your initial test. There are circumstances where you would prefer CT or MRI. Is there a benefit to choosing one over the other, CT versus MRI, contrast, no contrast, different kinds of modalities? Any comments there?
For me, as someone who does equity research, it's the test that's done that's the best test. And you know, with patients coming from all over the state, I just need them to get a image. And so for me, the easiest image to get is ultrasound. In our practices, you know, as a hepatology community, only 20 to 30% of people are getting screening. And so, you know, I'm excited about the data around abbreviated MRI, but is that really practical in terms of patients really having access to that image? So for me, it's whatever test I can get you to actually go get done. And so that's usually an ultrasound. And then if I have patients in those specific scenarios that we talked about, I may be able to get a triple phase CT, but I can very rarely in my practice get an MRI done in a patient who is not being followed kind of at our center and getting their imaging done at our center. So I have a limited kind of use for MRI outside of the transplant space in my practice.
And I agree. So it depends. It's practice specific. So over a decade ago when I was at UT Southwestern, the CT department, we would get triple phases on everyone. Now that might have changed. Our MRI division at Baylor, we do MRIs. But of course, if their creatinine is high, you wouldn't want to get a triple phase. And so it depends on the situation. Again, in this case, ultrasound would be sufficient, but this is part of the financial part of medicine that we're not really taught is, you know, this person has $1 million problem, right? They have chronic cirrhosis, portal hypertension. There's deductibles. We're not insurance people, but if it's towards the end of the year, just like all your patients want to come in and get endoscopies, be seen because they've used all their deductible, it never made sense to me because it's just going to reset the next year. But if you needed an imaging, if it's later in the year and they've already used their deductible and it's sort of borderline, I would consider maybe a MRI, at least as a one-time screening. So it's sort of case dependent. Again, in this case, I wouldn't, but just you have to take that into account for your patients. I think they would appreciate it.
Excellent.
So I think neither CT nor MRI actually meet the definition for screening. Neither of them are cheap, and neither of them are somewhat easy to perform. So I would continue to do ultrasound. And however, we do have low risks, and if we see lesions or there's something funny or they're reading increased echogenicity and maybe a portal vein thrombosis, and you know, if they say anything is funny or something has changed over the previous ultrasound, I mean, there's a very short trigger then to reflex to a cross-sectional study. Our preferential cross-sectional study is always MRI because it gives better detail of liver lesions. However, I don't know if you've ever had a triple phase or a dynamic MRI. You're sitting in the MRI scanner 45 minutes, and not every patient can do that. Some are claustrophobic, some need heavy sedation, and some just won't refuse to do it. And so I think triple phase CT would be the backup for those people. Again, if you've got as many people with cirrhosis have, you can have CKD. If you have CKD, you don't want that triple phase and getting a non-contrasted study. I mean, the worst thing you can do is order a triple phase study, and then the ultrasound tech in her good conscience looks at the creatinine, it's a little high, and changes it to a non-contrast study. Completely worthless. You can't see anything. So they should call you and tell you that, and then we say, yes, we're aware. That's why we ordered the MRI.
All right. All right, let's go to the next stage. She has clinically significant portal hypertension. She is progressing. She clearly is still drinking alcohol. What else? What do you all do? What are your ABCs to try to prevent this person, this patient, from going into decompensation? She's almost there. Lauren, we'll start with you.
So I'm usually looking for reasons that they may qualify for a non-selective beta blocker or a statin. I can't say that I am routinely starting statins in people without an indication for a statin otherwise. However, in my patient population, there is a lot of metabolic syndrome and most people need a statin. there are often primary care physicians who still feel uncomfortable about starting statins and cirrhosis. And so in a lot of my notes and communications with primary care doctors, I am kind of just reassuring them that we're comfortable with them starting a statin. In fact, we want them to start the statin. And so for its, lowering its risk for hepatocellular carcinoma and hepatic decompensation, in addition to all of the metabolic reasons for statins. And so I try to communicate in my notes with the primary care doctors, yes, please start that statin. Yes, please target that LDL goal. We want that as well for liver outcomes. And then if there's a reason that they need carvedilol as well, I'm trying to think of, okay, let's go ahead and get the carvedilol on. Not as many of my patients tolerate carvedilol as I feel like any patients in any study do. In my practice, I have so many people who end up discontinuing carvedilol or can only tolerate, the 3.125 and never really get to a therapeutic dose. I don't know if it's just it's an Indiana thing, but I don't have as much success, I feel, as many of the people that I hear talk about carvedilol in my practice with people actually taking it. And so those are the two kind of medicines that come to my mind in terms of preventing hepatic decompensation that I try to find a reason for in my patients.
Robert, tell us everything about milk thistle.
I'll skip the milk thistle, but in this patient, she's still drinking, and her PEth, as you could saw, was really high. So that's about like 3 to 4 drinks a day. The prevention of all these things that you mentioned, gut microbiome, antibiotics, probiotics, we can touch on that. The main thing that you can drive to her, so hundreds of doctors have told her, like, don't drink. She knows it herself. Her husband, probably tells her all the time. So we don't need to tell them. What we could do, and we've had discussions about this in PEth tests, now she has a hook. This is how I'd approach it in this specific patient. So the most important thing to prevent hepatic decompensation is you have a 2-year-old kid. Do you want to see them graduate? This will make her think about it. Everyone wants to do the right thing. She knows she shouldn't be drinking. All the prior hepatologists have told her, right? But she keeps it. We see this all the time. So we have that hook and we say, look, do it for your kid. More people will do things for other people than themselves. So that's number one. Now, that's kind of my personal approach to this case. As far as like antibiotics, prebiotics, probiotics, sure, that's great. But the more important thing is stopping the alcohol because she's going to decompensate further. The rifaximin SSD, when we were part of the 2023 trial to look at the dose specific, to find the dose of 40 milligrams, the recent study didn't pan out to prevent hepatic decompensation. She doesn't have ascites per her ultrasound, at least that I saw. So she can't have SBP. So then there's no point to put her on antibiotics. That's in this specific case. Now, sort of the data has changed for preemptive antibiotics on that. You already talked about the statins. Anticoagulation, the recent rivaroxaban looked at it was, I think, 3 months ago. They looked at preventing clinically significant portal hypertension decompensation, and it really didn't show any benefit. There were about 1/3 of the cases, usually they were Child's B, that actually bled more. So it sort of didn't pan out perfectly. So I also would not anticoagulate this patient.
Mitch, anything to add?
I agree 100% about the alcohol. I mean, that is clearly the most important thing you can do in this young lady, this patient, to prevent hepatic decompensation, because continued alcohol use is clearly going to make her decompensate, and a lot sooner than otherwise. In fact, if she stops drinking completely, she can reconstitute, she could regenerate, and her underlying studies her bilirubin could go down, and she could do even better. So I would push that really hard, and I would tell her, listen, you're drinking, you're not supposed to be drinking. If you decompensate, a transplant program is going to think 2 or 3 times about transplanting you, and you may die. Mm-hmm. You may not get a transplant. And you need to think about that. I think the thing about the kid is good. And I tell them, if you decompensate, you're just never going to be the same until you get your transplant. And then you're going to have to stop drinking then if you want to go through that process. So you might as well just do it now and save a lot of complications. What typically happens at that point is my next Press-Ganey score hits about 50%. And then I have to take modules to be a better, more compassionate physician.
Again.
Anyway,
let me say that, so she has clinically significant portal hypertension. She has 2 concomitant liver injuries, one of which we are sort of managing okay, the autoimmune hepatitis. The other one we're having issues with. It's a continuing insult to her liver. She's going to decompensate soon. How does that inform our follow-up? How do you particularly follow up those patients that you're expecting them to decompensate?
Well, any patient with cirrhosis like this that doesn't that's kind of in the child's AB has clinically significant portal hypertension, we're going to be following them every 3 months anyway, and I don't think anybody's going to follow any patient more frequently than that unless they've already decompensated and you're actively managing one of the complications of decompensation. In terms of predicting decompensation a little bit better, I mean, as we all know, our liver function tests, they get abnormal after you decompensate. So they're not a good predictor of decompensation, and neither is really the MELD score. The MELD score goes up after you decompensate. However, there are functional tests that are now FDA approved that do nicely estimate underlying hepatic reserve, hepatic shunting, and disease severity index. And in terms of disclaimer, I am a consultant to the HepQuad company, but there's fairly impressive data on that assay in terms of predicting hepatic decompensation. There's several papers on that. And we initially started working that in the developing that study in the HOLT-C study a long time ago. In terms of statins, there is some data, and that's also from the HepQuad. They looked at patients in their shunt study that were on statins versus off statins, and the patients that were on statins had better underlying liver reserve, lower disease severity index when they were matched for everything else on statins. So and there's some other data also, and a paper on that was recently published. But there's other data on statins, in fact, that it may not be deleterious to liver, even though it may raise liver enzymes a little bit, but it may further stabilize liver function and prevent decompensation.
100%. And, you of course open those letters from the insurance every day. Your patient is on a statin and has cirrhosis. Please consider discontinuing that. Having said that, I'd like to open it up to the audience. We have a couple of minutes if anybody has a question to ask. And if not, I'm going to pass the baton to Dr. Saab to bring us home. Thank you to our panelists.
So I have the honor of being the last moderator and last portion of this wonderful symposia. So I'd like to invite our panelists up here. Dr. Ed Lee, Professor of Medicine, Surgery, and would you believe it, Space Medicine. He's our go-to radiologist at UCLA, and we talk pretty much every couple of days about a patient and interpreting a result. Next, Nicole Rich, hepatologist at UT Southwestern, has a strong interest in chronic liver disease as well as liver cancer. And last but not least, probably the person why I did hepatology, Dr. Francis Yao, was my mentor a while ago. And as you know, he really changed the paradigm in not just the U.S., but the whole world of how we approach liver cancer in transplant candidates with downsizing tumors, more than 8 centimeters to Milan criteria. So, Dr. Yao, thank you. So now our very young lady, as you heard, has had a concomitant diagnosis of autoimmune liver disease and alcohol liver issues. And now we're going to talk about how this lady develops a new lesion. So here's our disclosures. And now she's 13 years old, comes back, routine blood work. Her liver tests are not normal. Her platelet count is 120. Her AFP is 5. Her fibrous to her transoscopy score is 21, portal hypertension. And her PET test is so positive. She's seen addiction medicine, and she's trying her best to be absent from alcohol. So undergoes as extension of our examination ultrasound. Found to have a central lesion measures 2 centimeters. And this is followed by CAT scan, and it's being read as an LRADS 4 lesion. So a little bit of a review, and you heard this from the previous panelists about liver cancer screening. I'm going to ask Nicole about who she screens for liver cancer and just remind us about how she does in her practice.
Sure, and thank you again to the organizers for inviting us to talk about this important topic. So surveillance, as you mentioned, was discussed during the last session of the case, and talked about some of the barriers with that. In terms of who do we surveil, I think that that's also a challenge. This is straight out of the most recent ASLD practice guidance, but is not without controversy. So we know, I guess to back up, what we're basing our surveillance population on right now is based on this cost effectiveness threshold that was established basically if a patient has a risk or a population has a risk of over 1% annually, which is relatively arbitrary and may change as we have new blood-based biomarkers. But with that being said, the populations that we know clearly are at highest risk are anybody with cirrhosis of any etiology. So that includes autoimmune hepatitis, as in this woman. I think some of the more controversial part of this is in whom we do not have sufficient evidence to screen, includes those patients that we see very often in our clinic in contemporary hepatology practices, which is non-cirrhotic MASLD, as well as hep C, those with stage 3 fibrosis who've achieved SVR, where we know that they have risk of HCC that's non-zero, but does not reach that 1% per year threshold. And then as well as, patients with chronic hepatitis B, we use the PAGE B score to sort of risk stratify them. And those with a score of 10 or higher should be surveilled.
One thing before I forget, I'm sure you also all read the most recent AAC guidelines, hepatitis B. And now they're recommending screening in select individuals who cleared hepatitis B virus after a certain age. So keep that in mind. We're not going to talk, and then how effective is screening? How many people are getting ultrasounds, and is it issues with the physician, with the patient, with the system, access to care? How are we doing?
I think it's a combination of everything. Dr. Nephew mentioned that the utilization, uptake of HCC surveillance is extremely poor. It's worse than almost any other cancer. I think part of that is due to we're still not in the USPSTF guidelines, which I think fighting for that. But we know that in the US, uptake of patients with cirrhosis who we're surveilling is about 25%. So when we talk about broadening to some of these populations, such as non-cirrhotic F2, F3 MASLD, we're not even surveilling the cirrhotics. So it's definitely a capacity issue, equity issue, as was mentioned. And a big part of that is that it's radiologically based. Thinking about MRI, there's a huge lack of capacity there. Ultrasound's very operator dependent, as was mentioned, and is very variable. So, but we know that utilization is poor, and I think that this is where some of the blood-based biomarkers really have the potential to improve the uptake.
Yeah, let's keep on going. And then Ed, LRADS. That's like a different language to me. LRADS 2, 3, 4, 5. How is that based on? What is it based on? How do we use it in practice?
So the LIRAD, it started 2008 as some of the radiologists got together and decide they need some sort of standardization of imaging HCCs and diagnosing based on the imaging only without the biopsy. And they correlated throughout the 3-year studies. And 2011 is the first time we actually officially published the LIRAD studies. And it goes from, LIRAD 1 all the way to 5, and there's M, and there's a different type, like a treatment outcomes can also be relying on the LIRADs most important thing, I think, especially for hepatologists and for interventional radiologists, is when LIRAD 3 and 4 and 5. So LIRAD 3, which has probably about 20%, 25% chance of being HCC, but still there's a probably that could be a benign. Whereas LIRAD 4, now you're looking at 75% chance of ACCs or probabilities with reasonable sensitivity and specificities. And when we get to LIRAD 5, we now almost 90 to 95, 100% specificities if they're big enough lesions, and where they're less than 2 centimeters, the specificity changes a little bit and sensitivity kind of decrease, but still very good sort of overall predictabilities. And that's what we use without any biopsies.
So Ed, I have people have Fontan. Can we apply LRAD's system to Fontan patients, other conditions?
So unfortunately, there are several incidents where the LIRAD doesn't apply, and one of them is the Fontan patients or cardiac patients, cardiac decompensated patients. So those patients probably still best option is to do either biopsy, or they have to have additional criteria to maybe include them into higher suspicions, but still we don't have any data right now to confirm that they're LIRAD 5s now.
So this is only for people with cirrhosis.
Correct.
And in difference between LRADs 4 and 5, how difficult is this? But she's rated as an LRADs 4.
So I think it becomes difficult for her because of, first of all, their size criteria. Her tumor is right at 2 centimeters. So it's like right at the borderline when it becomes, threshold for the tumor size. As I mentioned earlier, the tumor size less than 2 up to 2 centimeter, the sensitivity decreases down to about 60%. Whereas the greater than 2, it becomes 80%. So again, for her, I think she's right at the borderline. I think, it depends on her other conditions. She may require a biopsy, or we may have a short-term follow-up that could maybe lead us to maybe LIRAD 5. Again, the conversion rate from LIRAD 4 to 5 within 6 months is about 30%. So still, there's a chance this may not become LIRAD 5. So again, biopsy may be warranted.
So for Dr. Yao, let's say the lesion measures 1.8 centimeters, LRAS 4, positive PET test. Her liver function is rather intact. Where would you go from here? Would you biopsy it? Would you wait to get to 2 centimeters? What would you do?
If the lesion is 1.8 centimeter, you have time.
Okay.
So I think that is reasonable. I would, do an MRI just to make sure that, the MRI is not showing the features that would make her LIRAD 5. If it still doesn't, I would probably not do an invasive biopsy, but to watch and repeat either CT or MRI in 3 months.
3 months.
However, this is a 2 centimeter tumor. My approach would be more aggressive in terms of biopsying, make sure I make a diagnosis, because she may be eligible for transplant. Now, alcohol, that is a separate issue, is a challenging case. But, if you hit a 2 centimeter, you don't want to wait too much longer because you have transplant as an option. Yeah. And then the 2 centimeter, I think that, you need to deal with it a little bit more aggressively than less than 2 centimeters.
Are you routinely referring everybody with a 2 centimeter tumor for transplant, alcohol aside?
Well, the transplant criteria is that they meet T2, Milan minimal is 2 centimeter for a single lesion. So, it brings up a good question. Do all these patients need a transplant? Neil Mehta has done a study saying that a lot of these patients probably do very well with local regional therapy if they're not resection candidates. So a lot of times I think that we have to think more about who absolutely need transplant. I mean, there's going to be differences in priority that's being implemented based on tumor characteristics. So a single 2 centimeter tumor, if they respond really well to local regional therapy, they have normal AFP after treatment, the probability of them dropping out from the waiting list in 2 years is 2% versus 25% for everybody else. Yeah. So you don't really need to do transplant on every patient meeting that criteria. Yeah.
What we're struggling with at our institution is we treat people with local regional therapy 3, 4, 5 years ago, and now we have people on the wait list whose tumors have not recurred, or they may have recurred once and they've been treated again with local regional therapy. What do we do with them?
I would just watch. Yeah, I would just watch. I know that preemptive transplant is still being practiced here, but I think that you can monitor them closely every 3 months, if they don't have recurrence, they may do very well. I've had patients doing very well without transplant for 10 years. So I think that we have to be a little bit more judicious about who to select for transplant.
Nicole, who do you biopsy? Which lesions do you think about doing a biopsy? Which one do you follow the scans?
I kind of agree with what was already said. Obviously, anybody with a 2 centimeter lesion or more, especially if it's, if it's LR4 or LRM, I would biopsy pretty much whether they're a transplant candidate or not. Definitely if they are a transplant candidate, because you need to confirm that they are either LR5 or biopsy proven to get MELD exception points from UNOS. So definitely in that situation. LRMs, a lot of those are either mixed tumors, HEC mixed with cholangio, or are intrahepatic cholangios. And so I biopsy those for sure. And then, as you mentioned, the 1.8 centimeter, I mean, that's the real challenge. I agree. I typically follow those with MRI. I think this kind of also speaks to the CT versus MRI question. I'd kind of alluded to one of the benefits of MRI is that we can get those ancillary features that can actually kind of upgrade them from an LR4 to LR5, T2 hyperintensity, presence of restricted diffusion, which you can't get that information from a CT. So, I tried to get the MRI, but I would biopsy in those situations. I think another tough thing is those patients with tumors high in the dome, you can't always biopsy them safely. And so those are a challenge as well.
Ada, are there any advantages about CT over MRI that we need to know about?
I think that Nicole just mentioned, I think that's the biggest advantage of MRI, which is, again, you can get a lot more characteristic of a tumor with MRI than the CT. I think CT simply has only 3 phases, where MRI, we can do up to even 7, 8 different phases with the different informations will give, and I think, more characterization of the ACCs.
I would also mention that with MRI in a patient with ascites, is very suboptimal. So if they have large ascites, you get MRI, very often you get a non-diagnostic or very suboptimal.
So what do you do in that situation?
If they don't have problem with the kidneys, do a quad phase CT is probably better.
All right.
Just to add one more thing, we didn't mention, but contrast enhanced ultrasound is an emerging, modality for HCC diagnosis. I think its role in screening, some people talk about, well, maybe you could do same day CEUS with regular ultrasound to kind of get your surveillance and diagnosis the same day. But UNOS has recently adopted, as of a few months ago, they now will accept CEUS, and CEUS has its own LIRADS. A classification score for diagnosis for HCC. So the benefit of that is the contrast is very benign. I can speak more to that, but it's basically a gas bubble that I guess they breathe it out. There's not really any toxicity, hepatotoxicity, renal toxicity. I don't know if it's really widely available at all centers. Probably not so much in the community, but I think that's an emerging modality in these patients that still have indeterminate lesions.
I agree. I definitely think there's a role for the CEUS. Over the years, the BCLC group is very down on it because they claim that it cannot differentiate between intrahepatic cholangio versus HCC. But then, all the other studies are not great in doing that.
So are you guys both using it in your institutions?
I think that having MRI, CT, contrast, I think we're very selective in using CUS. So very, very seldom that we have, difficulty with the standard modality.
How about you, Nicole? Are you using it routinely or?
Pretty regularly, both in the research setting. We have a very avid radiologist with CEUS who's involved with the LIRADS group for that. So we do use it pretty routinely, but mainly in these indeterminate cases outside of research studies, LR4s or LRMs that are not really amenable to biopsy.
What do you think, Ed? Do you do it at UCLA?
We do. So we use for investigational mostly, but we just recently adapted into our clinical practice as well. It hasn't been actually affected our liver transplant patient or actual patients who's treated it, but we're doing for the detection purposes. Actually, the contrast enhanced ultrasound LIRAD system specificity is actually as close to the CT and MR, which is about 85% to 90%. So eventually, I think it may get adapted into the ASLD as well as OPTN, I believe.
And it's for screening purposes.
Correct.
Okay, that's interesting. So she comes back and she follows Dr. Yao's advice. That repeats the MRI, and now her tumor has grown from 2 to 2.3 centimeters, and now it's being read by our radiology colleagues as being an LRADS 5. So let's go back to her. Her platelet count's 120,000. Still has she had a positive PET test, and her transient elastography was 21. Francis, what would you do from here going forward?
So I think she has clinically significant portal hypertension. And I cheated a little bit in the last session. There's recanalized umbilical vein on the ultrasound. But if you look at the venous 7, with a medium stiffness of greater than 20 and platelet count less than 150, that would be in this probable clinically significant portal hypertension group. So I know that a lot of surgeons, they would use a cutoff of 100 for the platelet count to say, okay, let's resect. In this particular case, I'll be extra careful about it. I would definitely do more studies to confirm it, whether it's endoscopy to look for varices, or even doing a transjuggular hepatic venous portal pressure gradient to document whether she has portal hypertension or not. In a patient like this, if you do resection, and she decompensates, portal hypertension is a really important determinant for decompensation after resection. So if she decompensates, you really don't have transplant as an option immediately. So you'll be in trouble if she decompensates.
Nicole, how about in your institution? Do you guys use a Baveno for risk stratification, or because I think our surgeons still use a platelet count, like Dr. Yao mentioned, only, and not the Baveno score.
We don't use the Baveno. I mean, we do use the platelet count. Our surgeons, again, use that kind of informal platelet count of 100. We'll calculate the FLR, the future liver remnant. Again, it depends the location of the tumor. This, I think, was called central, so this is probably not going to be a great resection candidate. I think it is important to point out that there's been a lot of advancements in laparoscopic liver resections, as well as, other minimally invasive robotic liver resections. So if you have that available, again, I think that the risk of decompensation is much lower, particularly if it's a peripheral tumor. But I agree, you want to consider the patient's kind of overall trajectory. This is a patient that through the course it has not had the best compliance, is still drinking alcohol despite knowing of their liver disease for some time, may not be the best transplant candidate. Patients that get resected are eligible for immediate MELD resection points, exception points if they do recur. But again, this lady, I'm not sure that she is a transplant candidate at this time. So I think you would want to be wary about that and think about local regional therapy.
Ed, what are your options? Central lesion 2.3, LRS 5. Dr. I was concerned about clinical significant portal hypertension. What do you recommend as a radiologist?
So as just this slide shows, when the ACC is not a curative, I think the next level is what we still consider as possible curative intent treatments. And I will do what Dr. Saab tell me to do, usually with my hepatologist, but, we'll discuss at the tumor board, and there are different options for those tumors. There's ablations, a microwave, RFA, cryo, different flavors of different institutions. There's chemoembolizations or radioembolizations, something that we prefer to do for the different reasons. And obviously there's a SBRT from the radiation oncology perspective. And nowadays, I think for someone like with a BCLCB, at our institutions, our preference is either ablation or the radial embolizations for the patient preference and patient, quality of life purposes after the treatments.
President, at UCSF, how do you guys deal with this? You guys doing chemoembolization, radioembolization, if she wasn't a surgical candidate?
I think we do a lot more Y90 radioembolization than TACE now. Basically, I agree with what Ed just said. We do have some patients, if they have a slightly higher bilirubin, more than 2, we would use SBRT or TACE. So we use a cutoff of 3 for TACE, and you just cutoff of 2 for the bilirubin for Y90.
And what's been your experience with the SBRT?
Our first line is still Y90. I think that data emerging, the SBRT is also very good, but we, just center expertise is the key. Doesn't mean that one is better than the other, but centers are more experienced with Y90. We'll stick with it.
Nicole, how about your institution? Y90 chemoembolization?
I agree with what they've said. I mean, I think Y90 in the US is now the mainstay, is pretty widely available even in the community. I think we've really moved away from TACE largely. I think, we use a lot of SBRT at our institution. Again, we have, the rad-onc kind of capacity. I think, again, it's really based on your institutional expertise, requires multidisciplinary discussion. I think it's important to just point out there's really not any head-to-head data comparing these modalities. And, a lot of the data from HCC is coming out of Asia and Europe where they do not use Y90 at all, pretty much. So I think that's something to keep in mind, especially when you're thinking about interpreting some of these kind of combination trials, which is kind of the new frontier of HCC, combining IOs and LRT. But Y90, I think, is the standard in the US.
Yeah, there are a couple.
Question for me is over the past 20 years, see this pendulum swing completely. It used to be a death sentence, and now it's a chronic condition. Dr. Yao, sorry.
Oh, I'm sorry. So the two studies looking at SBRT as a bridge to transplant, they both is not a randomized control study. One from Toronto, the other one from Hong Kong. Looking at SBRT as a bridge, actually, these patients have done very well.
They what?
Comparable, yeah.
Okay. Right. And this is the landmark study that published over 10 years ago that changed the whole paradigm of how we approach liver cancer. Downsizing people from Alzheimer's to Milan. So let's imagine this young lady undergoes ablation, and then she's referred for transplantation. She's being, off alcohol, addiction medicine, very motivated. And now the cancer recurs, and she's not candidate for local regional therapy. So what is the role of immunotherapy in people waiting for transplantation? Nicole, do you have any experience in these individuals?
Yeah, I think that this is one of the new frontiers is IO. And as you mentioned, I think it's FDA approved for the treatment of unresectable advanced HCC. However, it is being used in earlier stages, being thought of as a bridge to transplant in people with earlier stage tumors, particularly these BCLC-B patients that have infiltrative tumors or multifocal bilobar disease. And then even in the community, sometimes in early stage disease, they're being used by medical oncologists because they're feeling very comfortable with these drugs. So we are getting this, I'm sure most of the folks in the audience are being referred these patients for transplant that have some IO exposure. I think the key thing to point out, there's some really great data now out of Mount Sinai where I think they've done the most of these from Parisa to Parisian, where they've reported their experience. They've transplanted many of these patients safely without the occurrence of rejection, significant rejection that was kind of raised in some of the initial case reports when IOs were originally being used. So I think importantly, you have to consider the washout period. We don't know the optimal washout period. There's prospective kind of multi-center studies ongoing, but most centers, it's about 3 to 6 months of washout. So that's what we do is at least 3 months, ideally 6 months. So 6 months works out because most of these patients are trying to get MELD exception points, which they need to wait 6 months for anyway. So what we do is we list them, begin the washout period, we're monitoring them on the list, and then we transplant them after 6 months.
Do they have to be off immunotherapy for the MELD exception?
They do not.
Okay. Dr. Yao, what's been your experience?
Yeah, Parisa Tabrishian is collaborating with us in the MERITS LT consortium.
Okay.
And then we developed this Vitality consortium just to look at, immunotherapy in combination local regional therapy. So primarily we are looking at patients with more advanced stage HCC that's tough to downstage, and then we add immunotherapy. We're able to get some patients, to transplant successfully.
Yeah.
So the data is still very preliminary. I should mention that, combination of local regional therapy with immunotherapy is a hot topic. It's been published in like the EMERALD-1, the LEAP-012. But what is really important to remember is that the jury is still out on combination therapy because there's not a survival benefit. Maybe progression-free survival is better with combo, but not overall survival. So I think that there's still, some consideration about waiting for more studies to look at the benefit of combination therapy, but as a bridge to transplant, it seems to make more sense. So we are not using immunotherapy routinely in patients waiting for transplant, but only the ones with higher tumor burden, difficult to downstage. Our algorithm is really the ones who don't respond great to local regional therapy, we add immunotherapy to it.
The only other thing I wanted to add is, I don't know if other people in the audience have had this experience, but we've done a lot of outreach with our medical oncologists because they are hearing a lot about IOs for HCC, but they don't, I think, have a great understanding of the transplant indications and the fact that we will transplant some of these later stage patients, particularly if you look at IMbrave 150 or Himalaya. Those were advanced patients, some of which with tumor thrombus, tumor in vein, or extrahepatic disease, 10% of those had complete response with IO, meaning that they had, no disease. So those patients can certainly be transplanted. UNOS will actually grant them MELD exception after 12 months of stability, so I think that, that's a key thing for us as hepatologists to work with our medical oncology colleagues to kind of inform them that we want to see these patients early in the transplant clinic.
Right. And does it impact you at all when you do local regional therapy, whether on IOs or not? Does it impact Y90 or?
No, I think it really it helps the patients to get much better, at the different level. And as Dr. Yao mentioned, I think one of the hottest topic currently in interventional radiology is the combination therapy. There's several studies recently, last couple of years, from mostly Asian Pacific regions, prospective study that shows the chemoembolization combined with the immunotherapies or secondary immunotherapies has shown significant improvement in their survivals. And I think it's coming towards us as well too. And the next line is probably the radioembolization combined with the immunotherapy. Potentially will be the, even more benefit. Hopefully that's what we're looking for in our.
We're definitely looking at Emerald Y90 and some other studies. I had a very interesting discussion with an oncologist recently. So, 10% of patients, they responded great to immunotherapy. And then they're looking at 5-year survival, 60 to 70% if they have a complete response to immunotherapy. So the discussion is, does this patient even need a liver transplant to stop the immunotherapy and then wait for transplant? Yeah. So that's an interesting discussion that we never thought of, 3-5 years ago.
Yeah, it's been so refreshing. And then she might need a transplant, and then, as you know, the MELD 3.0 was created to deal with disparity in health with women having low rates of transplant than men. And initially, data looked very good. Women were transplanted at higher rates than before. And then this paper was published recently that argues that benefit may no longer be there. That the MELD 3.0 did accomplish what it did initially on, but today, that benefit may not exist. And Francis, do you have any comments on MELD 3.0 and how it is today?
Yeah, I think this is a really challenging question because, for all these years, we see a disparity, a gender-based disparity. Female patients have a disadvantage. And then as we look deeper into this, is a lot of work by Jen Lai and her colleagues at UCSF, is really the height. There's a short stature that is a major contributing factor to this, gender-based disparity and higher waitlist mortality. And in the latest publication, she, proposed like a height of 5'5" or lower to be getting more priority. So I think that if you give some priority to gender without taking into consideration of the height disparity for larger donors that don't fit into these smaller stature patients, then you're going to not see as great a equalization or try to balance the wait list outcome. If you don't account for the height, you may not be able to see as good an effect. That would be my interpretation of this study by Tanaka.
Yeah, I think they argue the same thing. I think we need AI for this. So we have about 4 or 5 minutes left. I want to turn the lights on and invite you all, if you have any comments or questions for our distinguished panel here on the management and approach to liver tumors and liver cancers. All right, but I'm going to thank our great panelists. Wonderful session.
Okay, thanks to all of you for hanging out with us. This is called Liver Connect Wrap-Up, or what Kim learned during the last 2 days. So we started off with viral hepatitis. Dr. Jacobson gave a great memorial lecture talking about the AASLD guidelines, going through one by one. If you haven't read those, please do. He did an excellent job of sort of bringing those home clinically. Clearly, we're going to be expanding patients to more patients in terms of treatment and functional cure. Sort of the holy grail for hepatitis B is on the horizon. New therapies coming in the future. But clearly, increased need for education for all of us as to what is functional cure, who do we treat, and how do we get access to surface antigen, which is going to be critical in making those decisions. We moved on to cholestatic disease. Dr. Fawaz gave a very nice talk on IBATs, talking about the rationale for intestinal bile acid transport inhibition, looking at some of the data that was presented, just looking at itch, for example, and the reduction in itch that could rebound if changed over to placebo, but then comes right back down under control and is sustained under control over the time period of treatment. Some interesting data here, though, which is looking at not just itch, but looking at are these medications beneficial in terms of overall survival. This was an interesting study that looked at serum bile acids. We know they respond, and we know that the response matters, but we also wonder whether they could have effects on long-term outcome. This was data from the GALA looking at maralixibat and looking over a long period of time in terms of years, and just looking at event-free survival seemed to be improved in the patients who were being treated with maralixibat. So could these be used as therapies for underlying disease as well? Dr. Sokol looked at Alagille syndrome, something I know absolutely nothing about, but again, looking at the cholestasis-reducing effects of benzofibrate, which is a PPAR on survivors in patients with biliary atresia who had native livers. Again, a phase 2 trial, but looking at the ALK Phos changes, pretty significant change in the mean ALK Phos in patients who were treated with benzofibrate, and again, bile acid changes as well as microbiome changes in this small group of patients that were treated. Dr. Cowdley gave an excellent overview of cholestasis, and really we're starting to change the way we think about cholestasis, right? Now trying to risk stratify patients, maybe moving toward personalized medicine, but risk stratifying patients based on the phenotype of the patient, based on the baseline variabilities, based on our response to ursodiol, and based on fibrosis score. This was a beautiful slide that looked at the association between bilirubin and ALK Phos and the risk for liver transplantation. And you can see the hazard ratio changing as you go above 0.6 and the risk that you're going to have a liver-related outcome. And then on the right, this beautiful slide that looks at the percent of time that patients are above the upper limit of normal for alkaline phosphatase, as well as the upper limit of normal for bilirubin. And you can see the longer you are outside of those normal ranges, the worse your outcome, right? So, and so it's ALK Phos and bilirubin, and we need to pay attention to this, and we need to move more toward normalization. So we recognize that there are FDA-approved treatments for PBC, ursodiol way back in the 1990s when I was well, actually, I had already finished fellowship by then, but anyway, obeticholic acid, which we no longer have available, but now we do have 2 therapies for PBC. Unfortunately, no current FDA-approved therapies for the treatment of itching or fatigue, so these are things that we need to ask about in our patients and try to help them with in any way that we can until new therapies become available. Dr. Goyle talked about a tough disease that we don't have a lot of treatments for, PSC, but showed us data that ALK Phos reductions are associated with improved outcomes even in our patients with PSC. You can see on the right the improved outcomes in patients who are responders to ursodiol. AASLD and EASL guidelines both recommend considering ursodiol therapy in these patients who have persistent elevations of ALK Phos and GGT. A new therapy also presented by Dr. Goyle. Again, this was presented at EASL. This was a phase 3 trial looking at NOR ursodeoxycholic acid. And again, early data showing that about 15% of patients had a reduction in alkaline phosphatase less than 1.5 times the upper limit of normal and no worsening in the stage at 96 weeks versus only 4% in placebo. So maybe new therapies coming along. What about future directions in cholestasis? Individualized therapy is coming on the horizon. Biochemical response needs to be attended to. Complete biochemical response. Normalization of alkaline phosphatase. When do we test? I think all of us are suggesting that we test at earlier time points to look for response. And again, following fibrosis, as this is a predictor of outcome in these patients. Symptom measurement at every visit. Again, as we move forward, we will have therapies for pruritus. We will have therapies for fatigue. But again, we won't be able to use them unless you ask your patients about those symptoms. We then switched over to MASH. That was a whole, seemed like a whole day that we talked about MASH. Dr. Kumar talked about our non-invasive tests. We talk about these all the time, right? FIB4, ELF, VCTE, MR elastography. This is the problem. We educate our clinicians to use the tools that they have available, right? But the problem is our current tools are inadequate for personalized care. We haven't gotten there yet in MASH. Primary care, we need a test with high sensitivity. Even the presence of diabetes, we saw some data to suggest that the presence of diabetes may actually outperform a FIB4. Increasing triglycerides, a low HDL, again, further improves that sensitivity, identifying the patient who likely has fibrosis. And furthermore, increasing metabolic characteristics correlating with increased fibrosis. In referral clinics such as ours, we need testing with high specificity, and then not a lot of data, but can we start to use AI to better risk stratify these patients and understand who should come into treatment? We saw some data from Maestro NASH. You've known the actual results from resmetirom. But again, Dr. Abdulmalik looked at key subgroups. This is important for this medication, right? That it seems to be agnostic to gender, agnostic to degree of fibrosis, presence or absence of diabetes or age, both in terms of NASH resolution as well as fibrosis. And then furthermore, the ESSENCE trial, the primary endpoint for patients with MASH treated with semaglutide for 72 weeks, we now have this available. And again, resolution of steatohepatitis without worsening of liver fibrosis, as well as improvement in liver fibrosis with no worsening of steatohepatitis, significantly higher in the patients treated with semaglutide. On the right, similarly, when you combine the two, improvement of or resolution of steatohepatitis with improvement of liver fibrosis, 33% versus 16% in placebo. What about tirzepatide? Not currently approved, but again, a dual GIP and GLP-1 in MASLD with liver fibrosis. This was a phase 2 trial. So again, all these medications coming forward one by one, showing improvement, coming sort of as our armamentarium for treatment in patients with MASH. But a caution, right? We talked a lot about this. Dr. Brill gave an amazing lecture on obesity and talked about some early data on the GLP-1s and the risk of sarcopenia. You can see on the right in patients who had decompensated cirrhosis, not a great plan, right? We talked about this a lot because you lose muscle mass, you lose bone mass, and this is particularly problematic in our patient with cirrhosis. But again, as the panel pointed out, companies are starting to think about this with the addition of myostatin inhibitors and maybe osteoclast inhibitors to minimize the muscle and bone loss that we see with these GLP-1s. What about other therapies? Well, these are therapies that haven't yet been approved for treatment with MASH, but they seem to have some efficacy. The SGL2 inhibitor, dapagliflozin for MASH, again, you can see the primary endpoint improvement in NAS score, more than 2 without worsening of fibrosis, significant, and some of the confirmatory endpoints as well that we've seen. So again, something else that we can consider in our patient population who may be appropriate for other reasons. What about ACE and ARB inhibitors? These are something the hepatologists don't use, but again, if you look at the data suggesting the difference in death or liver-related outcomes seems to be an advantage in our patients who are treated with ACE and ARB inhibitors. So again, as hepatologists learning more about the therapies that we may have in our armamentarium, we just talked a little bit about statins. Every cardiologist for the last 20 years has taken one because they see the benefits in them. We are finding more and more benefit in our patient population, especially with liver disease. Again, looking at the association between statins and the use of NAFLD, a reduction, the use of statins and NASH, a reduction, and the use of statins and fibrosis. So again, coming into line with, again, therapies that we have available to use for our patients. And then finally, an oldie but goodie, metformin. This was a small study that looked at the risk of HCC. You can see on the right, metformin improved HCC survival. So again, thinking beyond the box of the therapies that we have, quote, quote, in liver disease, and learning more about the treatments that we have overall for metabolic disease, I think is something that will be important. We switched to kids. Dr. Schwimmer gave an amazing lecture on children, looking at the annual incidence of NAFLD in children. It's increased 62% from 2009 to 2018. It's a huge population that's going to come into our care as adult hepatologists. But looking at how we find those patients, in fact, ALT seems to be the screening test for MASLD in children. Not typically in the adult do we use ALT as the typical screening tool, but among adolescents with elevated ALT, 77% have suspected MASLD. The problem is this: the therapies or the diagnostics that we use in adult hepatology don't seem to be as reliable in our kids. So CAP is not associated with steatosis severity, and LSM is only modestly associated with fibrosis stage. So again, better diagnostics in our children and our adolescents who have or potentially have MASLD are critically important. We then switched to MET ALD, and Dr. Diaz gave a beautiful lecture on a wide variety of things. MET ALD is something that we all have to know about, and we are poorly understanding at the moment, but we are beginning to. So if you look on the right, looking at PEth, okay, we talked a lot about PEth and its utility. Clearly, there's an advantage of using PEth over self-report, and in fact, if you look at the right, the overall outcomes in terms of decompensation or decompensation-free survival, clearly different if you have patients who have high-risk PEth versus high-risk drinking reports. So again, PEth is just a better test for us to identify those patients at high risk. This is a beautiful study that was just presented at the liver meeting, but looking at cardiometabolic risk factors and that association. The new guidelines, right? Nutritional guidelines say if you have risk factors, don't drink as much. Well, patients don't know what their risk factors are, right? But the tight correlation between the more cardiometabolic risk factors that you have in association with alcohol use, there are some patients who likely can't take any alcohol safely, right? But again, that correlation that we're only now beginning to understand. So the definition of steatotic liver disease and that cutoff, that break cutoff for how much alcohol you can take before you're alcohol or metabolic, I'm not sure there is a cutoff, right? Because again, there's this very bidirectional relationship between the risk factors that you have and the amount of alcohol that you use. And when we look at MET ALD in particular, looking at the natural history of steatotic liver disease, you can see that the risk of liver-related events is higher if you have MET ALD as compared to MASLD alone. And how do we assess alcohol intake? Well, PEth is a selective test, and some people, as you heard from the people at the podium, some people use it selectively, some people just test everybody. What are we going to do? Is that a recommendation? Should we ask for permission or should we not? These are things that we should better standardize within the field. There is a need for standardized language to minimize the stigma that patients have with relationship to alcohol. And then what is the utility of monitoring PEth over time? Is there clinical utility, or is there benefit for the patient to see that the changes that they're making are resulting in a laboratory test that they can monitor? And then finally, data really regarding the kinetics following transfusion. We talked a lot about that. Lacking, we don't really know what to do in terms of a patient who has been recently transfused. And then we switched to alcohol. Dr. Morgan gave a very nice lecture looking at the diagnostics, right? In past clinical trials, sometimes we have used liver biopsy to make a diagnosis of alcoholic hepatitis. Again, looking at some of the emerging diagnostics, including cytokeratin 18. It's a major component of Mallory body, and there's increasing values as you move from alcohol use disorder to moderate alcohol-related hepatitis to severe alcohol-related hepatitis. And it was a strong predictor of steatohepatitis hepatitis in the STOP-H trial. But there are other markers that we can use as well, potentially moving forward: proteomics, extracellular vesicles, microRNA, and breath testing. So more to come. So emerging therapeutic targets and clinical trials for ALD. Again, this is an emerging field. Some looking at protecting hepatocytes by reducing apoptosis, some targeting inflammatory pathways to mitigate liver and systemic inflammation. And then finally, everything comes back to the microbiome, using the microbiome and alterations to try to affect outcomes as well. Dr. Single gave a very nice lecture on looking at real-world data on the treatment of alcohol use disorder in patients with alcohol-associated liver disease. Why is this important? We know that patients who come into care who are treated for their alcohol use disorder have better liver-related outcomes. So this was looking at 14 studies and looking at patients who were in AUD treatment versus those who weren't. Return to drinking was reduced, readmissions were reduced, decompensation was reduced, and there are some clinical trials, plus and minus, as to whether there was an effect on mortality. But again, this is a study that we always show when we give our own lectures, looking at AUD treatment, which was associated with a reduction in incident hepatic decompensation, as well as all-cause mortality. So what are we going to do with that information? Are you going to send them to somebody to get treatment? Are you going to initiate treatment? I think a lot of this is saying that we have to move treatment into our own clinics to better affect the liver-related outcomes. Finally, looking at a large group of patients that looked at the odds ratio for developing alcohol-associated liver disease after medical addiction therapy. Again, any pharmacotherapy significantly reduced the risk of alcohol-associated liver disease. And then finally, timely treatment. There's a lot of unmet need in this area. My colleague, Dr. Mellinger, in conjunction with her colleague, Dr. Winder, do a lot in terms of co-localizing this care in clinic, which is important. But again, on the left, if you look both either at the test cohort or the validation cohort, the percent of patients surviving who attended alcohol rehabilitation significantly higher than those patients who did not. And then finally, are there other therapies? Well, there's a little bit of data on semaglutide. Again, this is now moving into clinical trials, especially around addiction, looking at patients in terms of the reduction in alcohol use, the reduction in desire, the number of days that they drink in patients who are receiving semaglutide. So again, will we have some therapies moving forward that can affect, as we do with other oral therapies, the effects of alcohol or the use of alcohol? So in summary, this is really, in my opinion, an exciting time in hepatology. Things seem to be moving much more quickly than years ago when I first attended these meetings, but continued success we're having in a variety of diseases now, not just hepatitis C, both in terms of diagnostics, but also in terms of therapeutics. And I think finally, having our pediatric colleagues here is critically important, because now we're seeing the benefit of that continuum of care, right, across children, adolescents, adults. We're starting to learn more about PFIC. They're starting to learn more about how to transition care to the adults. So again, having this collaboration between pediatricians and adult hepatologists is critically important. So I thank you all for coming. Just remember to claim your credit. There's a QR code on the thing in terms of taking your test and getting your credits. That would be important. And finally, thank you again to our sponsors. Again, without sponsorship, we would not be able to hold this conference. So I thank you and have a safe trip home.